Dr. Fluid, good evening. This is Shafali here.
Hello. Hello. Oh, hello.
Good evening, doctors.
Hello.
Good evening, Dr. Sharma, Dr. Batra, Dr. Kumar, Dr. Rastogi,
Good evening.
and Dr. Arkade.
Good evening.
Good evening, everybody. I think Dr. Sunil is just heading up in hall.
Um,
I will be introducing the.
Hello, Dr. Mukul.
Hi, good evening.
Good
Good
evening.
evening, everybody.
Hello.
am I in the wrong place? Is it C?
Dr. Thuluvat, good evening. You are absolutely in the right place.
Okay, thank you.
Welcome to everyone for today's session, and we wish you all the very best. We'll let you know just before we are going live. Dr. Arkade, you will be notified.
Right. So I will just be introducing the chairpersons and Dr. Paul for the thing, and then
Yeah.
chairpersons will take.
Yes, and if you see Dr. Madan has just put in a flow of event in the faculty group, if you can just go through that.
Could I test my presentation?
Yes, sure, sir. Please share your screen.
Okay.
Akash. Atish, can you please check sir's presentation?
Yes, ma'am.
Yeah, Dr. Thuluvat is sharing his screen. Please check the bandwidth and everything, please. Sound.
Okay.
Can you see it?
Yes.
Not the full screen, sir, as yet.
How do I do that?
So you can go to the slideshow on top.
Okay.
And from the beginning, yeah.
Is that okay?
Yes, I can't see something. I think your screen is zoomed out.
Zoomed out?
Atish, can you see the screen clearly?
Yeah, ma'am.
Okay. So can you just move back and forth?
Can you see it?
Atish is all okay?
Yeah, ma'am.
Okay, sir. Thank you.
So what is going to be the flow of the things? I introduce the chairpersons, and the chairpersons introduces Dr. Paul, because that is what the flow has been sent on the WhatsApp group. But then I think Dr. Kaushal called up Dr. Taneja to introduce the Dr. Paul also. So, Dr. Yogesh and Rastogi, sir?
You can introduce Dr. Paul as well.
I'll introduce Paul first, sir. Okay.
Yeah.
Atish, just as you go live, 30 seconds before, please announce.
Yes, ma'am.
How is the discussions at this meeting?
Hello. Hello.
Good evening, Dr. Praveen.
Hello, Dr. Mukul.
How are you?
That's just fine.
Good. Nice to see you.
Okay. So I don't know what is going to be done in this meeting. No? Is going to present some case?
I think so. He's presenting case scenarios and discussion. Yeah.
Good evening, sir. We are live, sir.
Good evening, Dr. Ajay.
Hi, Ashish.
Good evening, Dr. Paul.
Good evening.
So,
How are you?
I'm good. How are you?
I'm fine, thank you.
So you'll be presenting few cases and then we'll discuss, right, Dr. Paul?
That is what Kaushal told me, that I present some cases and ask the panelists what they would do. It's more of a case discussion. At least that's what I was told I should be doing. I have selected about 5 cases. So we can see whether we can go through all of them. So maybe about 12 minutes each. Yeah, that's the way I looked at it. But if you don't have to go through all of them, it's fine with me.
I think we can touch upon the selected cases which we normally see in our day-to-day clinical practice. That will be a better thing for everybody.
Yes, let's go. It's already I selected and made the slides.
Okay.
So let's go through. I hope there will be some learning lessons for the trainees. I just mainly focused on trainees to think outside the box sometimes. That's the only thing I have tried to do here.
Okay, that will be good.
They're all real cases, so it's not made up cases.
Okay.
So everybody must be excited after the Chopra's win yesterday. Javelin.
Absolutely. It was a great victory, sir.
It was, and maybe I hope this is the beginning.
Yeah.
It will encourage youngsters to take up sports and excel in it. How is the attendance at this meeting? I know people are getting fed up with Zoom meetings.
We all are fed up, and every week there's one meeting, 1 or 2 meetings,
I refuse to do them now.
and
Time for in-person meetings.
Definitely.
very badly.
Attendance at our meetings we do, but the ASLD is also very low unless it is something about COVID. Initially, there was a good response, but now if you get 40, 50 people, that is the best we can hope for.
Especially Sunday, late evening, it's difficult for the attendee to attend.
Okay. So shall we start?
Sir, I think will it be giving us a countdown? Who is there from the tech team?
Sir?
Will you give us a countdown for starting?
Yeah, sir, you can start.
I think it's live already.
So you should have given us a countdown. Anyways, so good evening, everybody. Welcome you all to the final day of Inasl 2021 to Hall C. So we'll be starting off with clinics in hepatology, and the session will be chaired by Dr. Yogesh Batra, who is a senior consultant in gastroenterology and hepatology at Indraprastha Apollo Hospitals, New Delhi. Dr. Ajay Kumar, who is the chairman and HOD of BLK Max, Institute of Digestive and Liver Diseases, and Dr. Mukul Rastogi, who is the additional director of Department of Gastroenterology and Hepatology and Department of Liver Transplant at Fortis Hospital, Noida. And the session will be moderated by Dr. Paul J. Thuluvat, who is the medical director of the Institute for Digestive Health and Liver Disease at Mercy, and the director of the University of Maryland Advanced Hepatology Network, and also the director for the Center for Liver and Biliary Diseases and chief of gastroenterology at Mercy Medical Center, Baltimore, USA. So welcome everybody, and now I would please invite the chairpersons to invite the panelists and take the session forward.
Thank you, Dr. Day. First, I would like to invite Dr. Ashish Kumar, who is a professor and senior consultant at Sir Gangaram Hospital, New Delhi. The second panelist is Dr. Praveen Sharma, who is also senior consultant at the same hospital. Dr. Dinesh, are you there, Dr. Dinesh? We can't see you.
Yes.
Okay, Dr. Dinesh Jyotimani, he is a director at the Department of Hepatology at Dr. Rela Institute in Chennai. And Dr. Manoj Sharma, again, Dr. Manoj, are you there? Dr. Manoj?
I don't think Dr. Manoj is there.
Okay, so maybe you'll join late. Dr. Manoj is a professor and head hepatology at ILBS New Delhi. So over to Dr. Paul to start his cases.
Thank you. And I want to start with thanking the attendees, chairperson and panelists, and also my thanks to Inasl and Dr. Madan, Dr. Kaushal Madan for inviting me. I think yesterday was a big day for most Indians who had to wait so many years to get the first athletic gold medal. So we are all tickled to see this young guy, getting the first gold medal for our country. So what I have done is select few cases I saw in the last few months and hope that there is a learning point for the trainees. And this is nothing extraordinary. These are real cases that we see in everyday practice. So I don't have anything to teach you, only share what I have learned over the last few months. So I took cases from in the last 12 months. So this is a 50-year-old woman, white woman, morbidly obese, coming with abnormal liver enzymes for more than 10 years. She had been investigated in the past, and she had a liver biopsy in 2012, showed hepatic steatosis, and she carried a diagnosis of NAFLD. So she is morbidly obese with a BMI of 56, had type 2 diabetes, hypertension, hyperlipidemia, and she has had a history of lupus, but not on any treatment or not any specific symptoms that would indicate lupus. She had a previous cholecystectomy and hysterectomy, and she was on following drugs. The only new medication that she started taking was meloxicam. She had some joint pains, and her primary care physician started on meloxicam. Other medications she has been on for a long time. It's a strong family history of lupus, and brother had diabetes and hypothyroidism. Physical examination, apart from morbid obesity, there was no sign of chronic liver disease. So this was her initial workup when she came. Hemoglobin and platelets were normal, MCV was normal, A1C was 7.7, C-reactive protein was high, and immunoglobulins were elevated. IgG was elevated, but she, obviously carried a diagnosis of lupus. Autoantibodies were negative, and markers of hepatitis C and B were negative. So you can see on the table, I don't know what happened. Yes, that is when the meloxicam started somewhere before February, and the liver enzymes elevation seemed to correlate with that time, significant elevation in ALT. And this continued for almost 3-4 months before she came to see me. So she had imaging done by the family physician in CT initially in November 2020. She had a diffusely fatty liver. He repeated it because of the elevated enzymes, and it showed normal liver. There was the radiologist did not comment on the steatosis. So this was my differential diagnosis. It probably NASH, maybe worse by the meloxicam, delay from meloxicam, or because of the history of so-called lupus and immunoglobulin mildly elevated, could it be autoimmune hepatitis? I just want to know what the panelists would do in a situation like that. Morbidly obese women, all the typical features of a NASH phenotype, history of NAFL, comes with elevated liver enzymes for about 3-4 months. On new medications only is meloxicam and on steroid. Would anybody repeat a liver biopsy or just wait and see, stop the meloxicam and see what happens?
Dr. Paul, I think I would agree with you that this patient is of NASH because if you go to previous slide and can you go to previous slide?
Yeah.
Yeah. So till July 2020, her enzymes were not so high. So initially it was 96, 122 AST/LT, then 160, 189, 180, 190, which is very typical of NASH, especially she's morbidly obese and diabetic, hypertensive, metabolic syndrome. But something happened after February. So it could be drug induced by the meloxicam. So the one option is that we can stop meloxicam and repeat the uh, liver function test. The other option is since her immunoglobulins are high and she had history of autoimmune disease, so we can go ahead and do the liver biopsy. So that's what my thinking. So I would leave it to the patient to decide whether she chooses to stop the meloxicam and do a repeat test, or she would go for liver biopsy right now.
Personally, I wouldn't think about NASH here to start with from June 2018 because the enzymes are a little too high for just to explain by NASH. Maybe in May 2012, yeah, probably NASH. But yes, she has the NASH phenotype. But however, there is something else going on with her. She has hypothyroidism. She has strong family history. I think we should investigate more than just settling for a NASH diagnosis at this stage. Personally, yes, definitely she should go for a liver biopsy because if you identify something very much treatable, and we should treat that. And of course, we have to stop her NSAIDs because sometimes drugs can trigger autoimmune hepatitis, and then go for a biopsy. I would go for a biopsy.
No, what I feel is what I feel is probably patient is having NASH. There is no doubt because patient already had a biopsy done which was earlier, and the enzymes are okay. But while starting meloxicam, there is some problem which occurred to the patient. The enzymes have increased to more than 10 times. The ANA have now become positive, and probably IgG has also increased. Both delay and autoimmune exacerbation can cause increase in IgG, and sometimes there is a false positive ANA in patient who have started with some drugs. So it looks like probably it is a drug-induced liver injury, most probably because of meloxicam, because this is the only unsettling agent. So we can wait for some more time because the previous thing has not shown any fibrosis, there is no cirrhotic. We can wait and stop the meloxicam and wait how the patient is responding. If the patient enzymes have now reduced and patient is feeling better, I think we can wait and watch, and there is no need to do a biopsy just to confirm that it is because of the drug induced or because of autoimmune. We can wait for some more time.
I think Dr. Dinesh suspects there's something going on from 2018 onwards. There was some increase.
Yeah, I mean,
can I intervene here? You see, the issue is, I have a slight issue with say that we let the patient decide what they want. We all understand we are living in a world of informed decision making, and say jointly. I think you have to understand the social background of the patient and then comment on that part. My issue is definitely the patient had a background fatty liver. Whether the patient had something in addition to fatty liver or not, we are not certain about it. Two, we definitely know that the patient has a autoimmune liver disease, SLE, and it's a question is drug is precipitating or not. So the question will be based on if we delay the decision-making process in this case for treating autoimmune, are we harming the patient or benefit the patient? If the panelist will develop on that, on basis of that, you will decide, you will just stop meloxicam or wait, or you will go straight away for liver biopsy. But are we harming the patient by delaying the liver biopsy and intervening for autoimmune? I think if we have an answer to the question, then we can get an informed discussion with the patient.
Yes, yes. I agree with all of you. She was a morbidly obese woman. Biopsy is going to be a little bit difficult, but I opted, as Dinesh suggested, there are a few things did not fit in the normal clinical situation. AST/ALT right from the beginning was a little bit higher than normal. History of lupus, hypothyroidism, strong family history. So I decided to go ahead and do a transjugular liver biopsy because she was, BMI was 56. So this is the biopsy. You can see there was interface hepatitis and lymphoplasmacytic infiltration, very little steatosis. So this lady fits in with the clinical diagnosis and clinical and pathological diagnosis of autoimmune hepatitis. and she was treated with prednisone 40 milligram daily, enzyme returned to normal. So it is in our practice these days for asking for TPMT enzymes. The question I ask is, unlike the inflammatory bowel disease group people, we don't use very high dose of azathioprine. Is there a need to do TPMT enzymes, or will you start this patient on azathioprine, assuming that we are not giving a higher doses in this situation? I just want to know what the panelists do these days. We do in the United States, because the IBD physicians have started this testing it for medical legal reason. We do it routinely. I don't know whether it is important.
In India, I think we were not doing till recently, but recently, last maybe couple of years, we did start, but not at all centers. I don't know.
First of all, she requires more than just prednisolone because she's already obese. With long-term prednisolone, she's going to worsen all her metabolic parameters. Yes, definitely she needs long-term azathioprine on board in addition to a tapered low-dose steroids. But yes, TPMT mutation alone doesn't confer azathioprine side effect. There can be other mutations associated with azathioprine, which may not be going through TPMT. Like we have encountered such patients recently who developed severe bone marrow depression and hair loss, but he was TPMT negative. So that doesn't confer complete protection against side effects from azathioprine. So what we do is we just start them on low dose, see how they tolerate, and escalate accordingly. That's what we do.
But I think it is a common practice. We all do. We normally do not screen for TPMT because it is very uncommon in India, at least. So we go with the lower dose, see the response, see the TLC, see the hemoglobin. If everything is stable, we keep on increasing the dose till the ideal dose is achieved. If there is no problem, I think we continue with that. This is our practice that we do.
Okay, thank you. And we do it for medical legal reason because inflammatory bowel disease physicians started this trend.
Can I ask you a question? Can I ask you a question? Does TPMT predict about the anaphylactic or idiosyncratic reactions as well? Or it is only the dose dependent?
It is a dose dependent.
That's exactly the point. I will support what was said earlier by one of the panelists. That, see, I have a much bigger experience of using AZA in the setting of IBD. And I personally do not do it in every patient because dose dependent will be reversible if you are carefully monitoring it. What we are worried about is the idiosyncratic, and that's something which it does not predict. So that's the reason that we use. I agree with you that in certain cases, because of medical legal reasons, you may use it, but that's a different issue.
So for the residents or trainees, TPMT genotype is codominant. So the slow and fast metabolic pathways can be seen in the same person. And the real deficiency of the enzyme seen in less than 1% of the population. So it's very rare. And reduced enzyme activity seen in about 10 to 12%. So it's not that common. So my take-home message for the trainees is NAFL phenotype and alcoholism are very common. But let's think about other differential diagnoses when we see patients, especially when they have the subtle findings like the immunoglobulin, hypothyroidism, family history. So don't assume everybody has fatty liver disease or alcoholic liver disease. The next patient is a 52-year-old woman, again with abnormal liver enzyme. In this case, there was very good history of possible autoimmune disease. 2-month history of joint pain, muscle ache, AST, ALT elevated, globulin levels quite high, and a smooth muscle antibody strongly positive. The question I have to the panelists is, would anyone, this is a clinically, you would say, this fits in with our autoimmune sort of profile. Would anyone start treatment without a liver biopsy?
Liver biopsy is mandatory in diagnosis in defining autoimmune hepatitis. And not only that, it defines your necroinflammation as well as the fibrosis score. And when these patients get treated 2 years down the line, if you modify their treatment regimen, you have a baseline value, what it was like, because even with normal LFTs, you can have necroinflammation in the liver biopsy in patients with autoimmune hepatitis. So personally, yes, we do liver biopsy in these patients to confirm the diagnosis, to assess the severity of the disease as well.
I agree. You know, I see sometimes. I'm sorry, Dr. Kumar.
Yeah, maybe we would need a CPK also because she has muscle aches and all.
Okay, thank you. I agree that, you know, I see often patients from the community GI physicians, they suspect autoimmune hepatitis, start treatment, and then send to the patient to me. It's almost like a lifelong disease. By the time I see 3 to 4 weeks, enzymes are coming down, and the patient has a question, do I have autoimmune hepatitis? Do I need lifelong treatment? That makes it very difficult. So I tell all the trainees, do not start treatment because it's a lifelong treatment for almost 70 to 80% of the population. So do a biopsy before initiating treatment. And also you might find some unusual findings. So this was the biopsy. Again, as in the previous patient, interface hepatitis with a dense lymphoplasmacytic infiltration. So we started the treatment. Alkaline phosphatase was 276 to start with. AST/ALT came down, but alkaline phosphatase didn't come down much. And so the question I had is, has it delayed, like azathioprine can sometimes cause cholestasis, that could it be, or she has PSC or overlap syndrome with PBC, PSC? Should I add ursodeoxycholic acid or repeated liver biopsy, or would you consider anything else? And would you consider this is coming from elsewhere? So what do you think, what do the panelists would do in this situation?
We need to check.
I think you have worked.
Sorry, carry.
No, it's okay. You can go on.
So we need to check her gamma GT along with alk phos. The gamma GT is elevated. We know this is obviously coming from the liver. But if this is isolated alk phos elevation, she could have vitamin D deficiency. So that we need to correct that. And if this is ongoing cholestasis, yes, definitely we need to relook at the biopsy that she had to look for any features of bile duct injury, bile duct damage, like that. I presume she's AMA negative.
Yes.
So, you know, PBC is probably less likely. Probably I would add UDCA and then watch how the enzymes go if this is cholestasis.
Okay. So we did look at the liver biopsy again, and the pathologist said maybe some inflammatory cells in the bile duct, but they said sometimes you can see it in severe autoimmune hepatitis. And GGT was elevated. And so we, you know, I had two options, either to add on treatment. I did a repeat liver biopsy. I just wanted to see what's going on. And here the interface hepatitis has gone. Now you can see significant inflammatory cells in the portal tract with bile duct injury. So this patient has evidence of primary biliary cholangitis based on the second biopsy. So it was possibly an overlap syndrome. So we started on ursodeoxycholic acid, and alkaline phosphatase came down nicely, and making a firm diagnosis of overlap syndrome, autoimmune hepatitis. I have a few slides I just wanted to share with for the trainees, and then we can discuss this. You know, it's about 5 to 10% of people have this overlap between autoimmune PBC, PSC, and possibly AMA negative PBC in this case. So it is not that uncommon. And I think in my experience, Paris criteria is pretty good for this purpose. If you have 2 out of 3 PBC criteria, in this case, AMA was negative, but histology was positive, alkaline phosphatase was elevated. And you need to have interface hepatitis, and that is must. And if you have autoimmune hepatitis histologically, and then 2 of the PBC criteria, you could make a firm diagnosis with a very high sensitivity and specificity. And the prevalence varies. It is less than 10%. It depends on which criteria you use. And usually it is a simultaneous presentation like this patient. Rarely PBC followed by autoimmune hepatitis. And even rarer is autoimmune hepatitis followed by PBC. The prognosis is unpredictable because only very few case series, so it's very difficult to make any firm statements. This is what I do in my practice. If I see a suspected, if it is autoimmune hepatitis predominant, I started on immunosuppression. And then if there is any, it doesn't come down, add isodeoxycholic acid. I don't always do a liver biopsy. If it is a PBC predominant on histology, I start on UDCA first and immunosuppression later on. Or if you have early, the criteria fits with the Paris criteria, you can do both. So there is no guideline as such. You may have to use your clinical judgment. I will just stop there. So this is my take-home message. Overlap syndrome, they are rare. Consider it when therapeutic responses are suboptimal or biochemical abnormalities atypical. If you go back, this patient, biochemistry was slightly atypical for autoimmune hepatitis. Alkaline phosphatase was a little bit raised in the beginning. So I should have suspected that in the beginning. If I had looked at the biopsy with the pathologist a little more carefully, I would have persuaded them to say that the inflammatory cells in the bile duct a little more than one would suspect in autoimmune hepatitis. Any messages from the panelists on this?
Yeah, one comment from this side. Paired biopsy is important for stopping treatment of isolated autoimmune hepatitis. If a patient is improving and it is in remission, one can stop treatment if do the pair biopsy. So biopsy is important for the start of treatment and for stopping the treatment also.
Yes, thank you.
Dr. Paul?
Yeah.
For autoimmune, sorry, can I just slightly differ in that? For autoimmune hepatitis, we shouldn't aim to stop treatment. I think it's a long-term therapy because it can reoccur, can present as an acute presentation once you stop steroids in the long term. So it's a very tough call to stop after 3 or 4 years. So most of them will end up in maybe azathioprine monotherapy or the long term. So I don't know. I mean, I don't think we should stop therapy for autoimmune hepatitis. Is there any, Professor Tuluvat, you can...
Yes, my experience is 70 to 80% need lifelong treatment. And the more and more the hepatologists around the world who have an interest in autoimmune hepatitis feel if we decide on treatment, maybe do a liver biopsy as Dr. Rastogi suggested. And if the histology suggests that the disease is in total remission, then maybe give them a trial under very careful observation. I usually used to think men may be able to come off this long-term treatment, but my recent experience suggests that men are likely to go into relapse just like women. So I don't think there are any phenotype we can identify where you can stop the treatment. As Dr. Jyotimani said, it is a lifelong treatment, especially with people with advanced fibrosis, cirrhosis, or elderly patients. It may be better to keep them on azathioprine monotherapy at least lifelong rather than play with the medications, because some of them can go up and down, and you will not see some of the relapses unless you are closely observing them on a regular basis. So I agree with you.
But there's a subset of patients where autoimmunity has been triggered by either by infection or by drugs. So these patients, carefully selected, these patients, we could give a trial of stoppage of therapy and then monitor.
Yeah, thank you. And I saw last 2 months ago.
Dr. Paul? Yeah. So I'm not against the liver biopsy in autoimmune patients. But a typical patient who has the classical features of autoimmune, as you likely said, whether you want to go for the biopsy. But if you go by the patient point of view, if the patient asks you that suppose if you do a biopsy, which probably show the autoimmune disease, and you think that this disease will be lifelong and you will not be able to stop my medication for my rest of my life. So how important is to doing a liver biopsy at the subset and the first time? And suppose if you have started treatment and the patient is responding, so what is odd against like if I don't do a biopsy in this patient, because most of the time about 80% of my patient will be on lifelong immunosuppressive therapy for his autoimmune disease. So they don't want to do for a paired biopsy, because if you want to stop the treatment, you need to do again biopsy, which most of the patient denied. So that is very difficult, whether you want to continue or you want to discontinue. So practically every patient of autoimmune disease has to be on the lifelong therapy, because most of the patients, they do not go for the second liver biopsy. So your comment on this, what do you do on these patients?
Yeah, I try to sit with them and explain the 70 to 80% going into relapse. And it's interesting. A lot of people these days tend to say, I would rather, especially if they started with severe autoimmune hepatitis, they tend to say, I will stay on the treatment. And if I take them off prednisone, they are very happy. So I, in a way, try to discourage them from stopping the treatment, because there are some people who are so obsessed that they should come off all the medication. For those people, I recommend a biopsy if they would agree. Or I said we stop it and carefully watch the immunoglobulins and liver enzymes. And somebody suggested, I saw a patient 2 months ago who had a very acute hepatitis A, and liver enzyme won't come down after about 3-4 months. Very high levels, not just in 1,000. And liver biopsy didn't show autoimmune hepatitis. That was one of the concerns. You see, I gave her a short trial of prednisone because she was getting worried, and she was having symptoms. And liver enzymes drastically improved. In that patient, I decided to wean off the steroid, and I told her, if the liver enzyme go up, we'll repeat another biopsy. And those are the occasional cases. I still think she may have had autoimmune hepatitis, but I'm not sure because histology did not confirm the diagnosis. So there are rare instances I do that, provided the patient is agreeable to come for regular follow-up.
I totally agree. That's the reason that getting a liver biopsy is important. But there are not liver pathologists everywhere. Even you do a biopsy, sometimes you may not be able to pick up the typical findings of autoimmune. Then again you are in trouble. What to do? Because the patient is responding, the biopsy has not shown much evidence of autoimmune. Whether you want to stop it, you don't want to stop it. So there are many factors while asking a patient to go for the biopsy. That's important.
I totally agree. And it's an invasive procedure. Although complications are rare, it can happen. So
yes.
It is with the family and the patients, I discuss it and decide on the path.
So, for the students who are listening, I think liver biopsy is not that much easy to convince the patient, at least for the Indian scenario. So you can sit up with the patient, you can ask that it is mandatory. Most of the patient, they say yes, but there are many patients who say no.
So Dr. Manoj Kumar, our fourth panelist here, who is the head department of hepatology at ILBS, has also joined us.
Yeah.
So yes, sir.
Good
so
evening.
Maybe you can also just pitch in your opinion, sir.
Yeah, sure. From the next case, I will.
Thank you, Dr. Kumar. Next patient is an interesting young woman, Chinese origin, very well educated. She's quite lean with elevation liver enzyme and diabetes for 7 years. There is a strong family history of diabetes. A1C at the time of diagnosis was 13.5, so she was almost 26. The C-peptide levels range within the normal range, and glutamic acid decarboxylase antibody was absent, so they thought this was not type 1 diabetes. So she went to another university hospital where they adjusted the genetics, and they found that she has a mutation of HNF alpha, HNF1 alpha, and that is mutation that can reduce the transcription factors for the insulin. And she was diagnosed with HNF1 alpha MODY 3 diabetes. So these patients are very sensitive to sulfonylurea, and the physician appropriately switched to sulfonylurea, and she was very well controlled. But the reason she came to see me is she had liver enzyme elevation. At the onset of diabetes, it was normal. Then it was about 3 to 4 times upper limit of normal. Alkaline phosphatase up to 3 times. Rest of the liver tests were normal. And FibroScan, although fatty liver disease was the suspected diagnosis, was perfectly normal. Normal liver stiffness measurement, CAP score on the lower end. So she didn't, although she could have fatty liver disease, didn't go along with our FibroScan findings. Although many of you may argue that 20% of FibroScan may not be accurate. She had extensively worked up by the referring physician for autoimmune disease. Nothing was found. Ultrasound and other imaging modalities were normal, no steatosis. And FibroScan continued to show no evidence of steatosis or fibrosis. So the question is, do we do a biopsy here? Or could we make, with that history of uncontrolled diabetes before that, should we presume she has NASH?
I think two things I would like to know. One is history of alcohol being a young woman, it's a possibility. And the second thing is any alternative medications has she been consuming of late. That's sort of...
Yeah, she was not taking alcohol. She was had a doctorate, and she wanted to become pregnant. That's why she came to me and said, with this problem, liver disease in the background, it will be safe for me to become pregnant. And that's why she came to see me from another city. So I thought we need to do a biopsy here, and this is what the biopsy showed. Absolutely no steatosis, no inflammation, but marked perisinusoidal fibrosis in the lower panel, and very significant. And it is around the venules too. Any thoughts on this? She had serial FibroScans, which showed the same findings in a low normal liver stiffness, no steatosis. So I haven't seen this before, and it's a very unusual manifestation of diabetes. This is called diabetic hepatosclerosis. It is considered very rare, but autopsy series, people have done autopsies say that about 10 to 12% may have diabetic hepatosclerosis. But if you look at the number of cases reported in the literature, it's less than 20. It is hepatic sinusoidal fibrosis in the absence of any histological evidence of non-alcoholic fatty liver disease, usually seen in uncontrolled diabetes, and pathogenesis is unknown. It is thought to be a continuum of microangiopathy or oxidative stress secondary to uncontrolled diabetes. Usually atypical mixed pattern of liver enzyme. And there are only 2 cases with long-term follow-up, at least on data. It seems that although they have significant perisinusoidal fibrosis, the disease does not seem to progress. In this patient, at least, we have 7 years of FibroScans and no progression. Rare manifestation, but I'm sure many of our patients we call NASH because of the diabetes. Some of them may have this condition. And this has a better prognosis for, despite those histological findings, it looks like the limited data show they have a good prognosis. So, zebras are less common than horses, but if we cannot explain where the hoofbeats come from, just look for a zebra. this is just an interesting case. I learned that we assume, looking at the phenotype, any diabetes uncontrolled, we assume it is fatty liver disease after ruling it out. And people often wonder, should we be doing biopsies? And this helped me to educate her. And and she became pregnant, and she's going through the pregnancy now. And I think for her it was a little bit reassuring, at least limited data. But yes, Dr. Jyotiman.
Would this be reversible after controlling diabetes and lifestyle modification?
It doesn't seem to be. I told you there are only 20 cases reported, less than 20 cases. And they say it is not reversible, but it doesn't progress. And I have written this up as a case report, and I think it is accepted in digestive disease. So only for educational purposes. I know it is very rare, but we always think of people with fatty liver disease, because that's such a common thing. In my clinic, 90% of the patients I see is fatty liver disease these days, or cirrhosis related to that. So among them, sometimes when I see something unusual, it is interesting. I learned something from that.
My only concern is that microangiopathy and other vascular complications of diabetes occurs after many years, maybe after a decade of diabetes. And since she was detected recently only, so is it?
Yeah, when she had the initial presentation, A1C was 13, and she had proteinuria, and the nephrologist suggested she has mild chronic kidney disease. When you look at the creatinine was at the upper limit of normal. For a 26-year-old, I think she had. And again, this is very speculation that most of the patients who had diabetic hepatosclerosis had renal disease too. But that may be a signal that they have uncontrolled diabetes more than anything else.
No, my only issue is she has raised enzymes, that is the AST, ALT were on the higher side. But on biopsy, I don't think there is any inflammation in the hepatocytes and in the pericordial area, which is slightly odd to have. We cannot explain these things.
People have reported even rare cases of jaundice, because this perisinusoidal fibrosis seems to compress the ductules and can cause this sort of elevated liver enzyme and even significant elevation in alkaline phosphatase. So the amount of perisinusoidal fibrosis is quite significant in this. And yet they have an excellent prognosis. And we don't know what will happen in 20 years, but we don't have many long-term data on that.
What are the chances of getting cirrhosis in this scenario? Excellent case.
Yeah, I don't know that answer. I told you there are only 2 cases. My patient had 7 years of follow-up, at least on fibroscan. Another case report, 11 years, no progression, but we don't have a lot of data. I think we all assume many of these patients have fatty liver disease. So I told you one retrospective study of autopsy showed 12%. When you look for diabetic hepatosclerosis, they had it. And cirrhosis, I think it is uncommon, but this is anecdote. I just thought I learned something, and I didn't know about this condition, so I thought I will share it with you. The next one is a 68-year-old Black man with excruciating leg pain and weakness. And he had it for a year, and he was now wheelchair bound. He came to my clinic pushed by his sister in a wheelchair. He couldn't walk. He was almost malnourished, lost 30 pounds. He had a history of alcoholism and drug use, and he was abstinent for 1 year. And as expected, because of the history, he was drug seeking, and that was one of the things that everybody was thinking. This guy is looking for drugs now. Now he's off street drugs. He wants to use prescribed drugs. Liver enzymes were mildly elevated. Alkaline phosphatase was very high. It fluctuated for about 5 to 10 times. GGT was also elevated. And they found he has hepatitis C, but the pattern of liver enzymes was quite atypical. So he was extensively worked up by a neurologist in another hospital, and vitamin D levels were normal, muscle enzymes, cryoglobulins, muscle biopsy, brain MRI, EEG, CSF, everything was normal. But this guy cannot get up, and he says pain is excruciating. And most physicians, I would definitely, because of his history, thought this guy is seeking drugs. MRI showed mild spinal stenosis, but the neurosurgeon didn't think that could explain the pain or the symptoms. The liver biopsy showed advanced fibrosis, maybe early cirrhosis, but when you can look at the liver, it looked pretty good to me, and no masses, no infiltrative lesion. So because of his weight loss, and people were thinking, could it be he has some sort of malignant process? So this guy has alkaline phosphatase is, atypical for hepatitis C. What will you do next?
I would suspect some other source of alkaline phosphatase, maybe bone, because he has severe pain in the lower limbs, but I'm not sure.
Cardiac status, okay? Echo doesn't have dilated cardiac.
Yes, it was normal. His predominant complaint is, he says the pain is so excruciating, he cannot do anything. I think he was wheelchair bound because he was not moving, because he couldn't bear the weight. And the muscle started atrophying, and he lost about 30 pounds. That's why malignancy was there. So I agree. I think alkaline phosphatase at that stage, although GGT is elevated, you need to do you need to do isoenzyme in this situation, and 90% of that came from the bone. So he had a workup, endocrine workup, calcium, 24-hour urine, PTH, vitamin D. Only thing that was abnormal was fasting C-telopeptide. It is a marker of bone turnover, significantly elevated. And a nuclear bone scan showed diffuse uptake in the skeleton, suggestive of metabolic disease. But if you look at the metabolic bone diseases, there is a long list, but he didn't fit into any of those things. The question is whether to do biopsy of the bone. Would it give us any information? What is going on in this condition? Again, uncommon diagnosis. So I don't want to ask you guys what you think. Any
Paget's disease of the
she doesn't have Paget's on the skeletal survey. So again, we see so many hepatitis C, don't we? But we don't. This is an unusual. So this guy has a very unusual diagnosis: hepatitis C associated osteosclerosis. I will tell you what it is. Again, a very uncommon disease. So far, only 21 cases reported in the literature. So it must be pretty rare for a common disease like hepatitis C. So we started him on Epclusa. Alkaline phosphatase, I told you, it ranged for at least 6 to 9 months above 800, started dropping. And this guy had a remarkable improvement in the muscle pain. His C-telopeptide came down, pain improved. He came off all the narcotics because everybody was blaming him that he's drug seeking. His pain, when the pain improved, he could walk. And for the first time last Tuesday, he came to my office walking on his own. So amazing improvement with this is a rare condition, and it was very satisfying because he and his family were very grateful because everybody said this guy drug addict, alcoholic, so it is a rare disorder linked to hepatitis C. It is associated with rapid bone turnover. Pathogenesis is unknown. People have said if there are some 3 or 4 case reports from Mayo Clinic, they have tried all those drugs you use for osteoporosis, and some people have tried high-dose steroid, but thinking that this is immunologically mediated, precipitated by hepatitis C. But the only common theme when I look at all these case reports, all the patients who had this the bone scans were almost very diffuse increase in radioactive isotope throughout the skeletal system. And overt osteosclerosis, that is cortical bone thickness, may be seen in most patients, but in elderly patients may be absent like this patient. And treatment, there is only anecdotal experience. So I cannot say anything beyond saying that interesting case, think outside the box, do not make hasty judgments about our patients because of two things. He's a black man who has been drinking alcohol. People were very hasty to say this guy is wanting drugs. He's not who would sit in a wheelchair for more than a year. Somebody who was perfectly healthy. So rare condition. I have one more case and then we can have a discussion. I know this is extremely rare, but satisfying. Think outside the box. That's what I tell the residents. Common things common, but rare things do happen. And always don't pass judgment.
Well, we can
This is the last case.
We can take another 10 minutes. We leave 2 minutes for the summing up. That's it.
Okay, I will do this very fast. This must be a common situation. 58-year-old man, elevated liver enzyme, asymptomatic except for itching, high alkaline phosphatase for a year. It was normal in May 2018, and in October, this is what he said. He has obese, diabetes, hypertension, and he had recurrent pancreatitis since 2003. Although alcohol has been implicated, he believes that it started with exenatide, and it came on soon after he took that, and it's a well-known cause of pancreatitis. That was in 2003. And he had an intra-abdominal tumor removed. It's a fibrotic tissue, so mesenteric fibrosis was possible in the differential diagnosis. Only drug he was started recently, he participated in a clinical trial at that time called pemafibrate, PPAR alpha agonist, selective PPAR alpha agonist. And that's only new medication he was on. So as you can see, significant elevation in alkaline phosphatase, A1C 9.8, all autoantibodies negative except and a smooth muscle antibody, immunoglobulin IgG4, all within normal limits. So this is a guy, MRCP showed normal biliary tract, fibroscan, suspicious for cirrhosis, CAP score normal. So this is the differential diagnosis we had. We have PSC, AMA negative PBC, which is very atypical because it was a rapid sudden rise. Has he got IgG4 disease? Rare, but no. Could it be delayed? Pemafibrate, but pemafibrate is supposed to be a very safe drug. And I looked at the literature search. Not a single case has been reported. It is just like fenofibrate. Could it be part of the mesenteric fibrosis causing some obstruction? I have seen few cases of mesenteric fibrosis with the biliary obstruction. What do we do next? Liver biopsy, ERCP? Would you do ERCP with a normal MRCP?
Probably go with the liver biopsy to see.
Okay.
I was thinking more of IgG4 disease.
Yeah.
Recurrent pancreatitis, abdominal LFTs.
Pancreatitis and
Exactly.
the linking.
IgG4 levels were normal.
Yeah, I know.
But in the tissue, the IgG4 may be high if we could get some tissue for the.
Yes, yeah. So I just want to show you what is this pemafibrate. It is a PPAR alpha selective one. So theoretically, it's a treatment you give for this condition, not can cause that. So very rare. And he had an ERCP because this significant cholestatic LFT, and liver was normal. ERCP was normal. And this is the liver biopsy. I'm going to go through these slides pretty fast. We have only 3 minutes left. So significant ductal proliferation, pericholangitis, and advanced fibrosis. And the pathologist, this was looked at by multiple pathologists and some well-renowned pathologists. They all said he has biliary tract disease. normally RCP. But what do you think? My professional diagnosis is still good. Although I only drug I could implicate is pemafibrate, I couldn't find a single case. So the next question.
Were there any other features of DILI like eosinophilic infiltration, something like that? Sometimes.
No. No, he had 2 liver biopsy. I didn't say that. Both showed, and both pathologists said this is biliary tract disease. And the first liver biopsy was done during the ERCP. The interventional radiologist, interventional endoscopist did a transgastric liver biopsy. So we thought the tissue was not sufficient. So we did a repeat biopsy. This guy has fibrosis was significantly advanced. So we were a bit worried. The question is, yes, and a smooth muscle antibody. Would we give a trial of steroid? Would anyone give? Because histologically, pathologists said nothing to suggest autoimmune disease.
Well, I will give steroids, but not because I think it's a DILI, but because it's some sort of a biliary disease, which could be, the panelists initially raised a question of IgG4, or maybe something which we don't understand, some autoimmune manifestation, part of some fibrosis. It's a question of, so I will give steroids, but not with the premise of a DILI, but with a different premise.
I'm not asking because of DILI. I was thinking whether could it be something else? Yeah. Because DILI is a professional diagnosis, and pemafibrate theoretically is a safe drug. When I look at the literature, it has been suggested as a treatment for PBC.
Equally, in the absence of significant inflammation on the liver biopsy, do you think steroids are going to be beneficial? Yeah, it's very much debatable, actually. I would say stop the drug, what we think could have contributed to that, put him on some ursodeoxycholic acid and see whether it works.
We did, the pemafibrate was stopped. There was a clinical trial. UDCA was started. There was no response. And the question I had is, because he's diabetic, hypertension, steroid has potential complication, should I try obeticholic acid? We don't have any data on that. So I have requested the insurance to pay for the obeticholic acid because of a presumed diagnosis of AMA negative PBC. I don't think he has that, but that's the only way we can get the drug approved. I don't know. It's, not always we have a diagnosis. That was my last slide. I think we have 2 minutes.
I think this has to be discussed with the patient first, because even after the biopsy, we are not sure what we are doing. So we can say that because yes, we have stopped the drug, the anxiety drug probably, and there is no other option. You have not responded to UDC, and the only option which we have that may probably help you is to give a little bit of stress. Consent has to be taken from the patient and from the doctor, both mutually. If I am the treating physician, I will go for the steroids.
On his medication, we did extensive research. We went through his pharmacy, asked all the prescriptions that he had for the last 3 years. We looked through those. We could not find a drug apart from pemafibrate potential cost. Most of the other drugs he has been on for a long time. Do you think it could be small duct PSC?
At least liver biopsy should have shown features of PSC. It's just only bile duct regeneration, there's a ductal proliferation, which may not fit in with the good case of small duct PSC. I know the MRCP and ERCP showed normal ducts, but I would say still DILI would be the likely diagnosis than small duct PSC. Again, with small duct PSC, how do we manage?
No, the only thing is this patient is AMA negative. So how do we differentiate between AMA negative biliary cholangitis and PSC? And I don't think there is other way out. The biopsy, if the pathologists are not sure, because this diagnosis has to be made by the pathologist. If they are not sure what they are dealing with, even best of the pathologists have seen, and they're not sure whether it is a PSC, small duct PSC, it's very difficult to say from the clinical point of view.
What was the cause for recurrent pancreatitis? Was
Yeah, this is, his alcohol intake is more than normal, but he blames it on when he was started on exenatide. I looked at that, and it is a drug which is known to cause acute pancreatitis, but he's having recurrent pancreatitis. And his EUS pancreatic duct was normal. There were no stones, no strictures. So the question is, again, as you raised earlier, could it be IgG4 disease without elevated IgG? And because that would fit in with the biliary tract problem, sometimes it can fit in with the recurrent pancreatitis. That's why I put this question. Would we give a trial of steroids? I have debated on that, pros and cons, because this guy disease is progressing. I told you, he had 2 liver biopsies, almost 6 months apart. The fibrosis seems to progress quite rapidly. The first biopsy was done a transgastric biopsy by the therapeutic guy. So they are thin codes. So I thought maybe I would get a better. And these biopsies were looked at by multiple pathologists, some of the best in this field. And they keep saying, this is biliary tract disease. And so they don't give me even a differential diagnosis of anything else, say, except that so you saw the ERs, it is perfectly normal.
That's why tissue IgG4 levels can be done.
And the patient had mesenteric fibrosis. So is it possible that the same process is going on in the liver and pancreas as well? So that might justify a trial of steroids for that.
Yeah, mesenteric fibrosis, when I have seen, and it's a very limited number of patients, they usually have a mass effect on the hilum or the biliary tract. And I haven't seen diffuse disease like this. And so you're right, that diagnosis is a little bit, and nothing seen on the scan now of mesenteric fibrosis. So the question like everybody saying, could it be IgG4 disease? If you give steroid, what dose of steroid in a diabetic with a hypertension, obesity, how long do we give the trial? And I don't know the answer. I'm trying to try obeticholic acid. If it doesn't work, persuade him to give a trial of steroid.
Right.
Thanks, Paul, for presenting such beautiful cases and generating such a good discussion. We learned a lot of things. For the residents, please, I think the point that Paul highlighted, that don't be guided by the obvious, always be cautious about the certain things which are not obvious. So keep in mind other possibilities when you look at the first case, that just simple fatty liver, it could be having more than that. I think that's the key message that he gave us. He also discussed in detail, all the panelists discussed in detail about the issue of follow-up liver biopsy. And can you start treatment of patients of autoimmune hepatitis with or without liver biopsy? And on follow-up, whether to do the liver biopsy or not. Interestingly, he brought us to our notice the different disease entities. One, so-called diabetic hepatosclerosis. Two, we talked about hep C associated osteosclerosis. And thirdly, he diagnosed about so-called idiopathic biliary duct disease, which could be still open to question. And we'll be waiting to hear from you the follow-up or some other conference that what he did. If I am at your place, I will give a trial of steroids after discussing with the patient, but I would like to hear from that. Over to Mukul to say thanks to everybody. Mukul.
Yeah. Thank you, Dr. Paul, for presenting such an excellent, interesting, and informative cases. We can't thank you enough for sharing your knowledge and expertise with us. With this, I am thanks to all the panelists and my co-chairpersons and audience. Thank you very much.
Over to the organizers.
Thank you.
Thank you.
Thank you.
Big thank you to all the chairpersons, the panelists, and Dr. Paul Thulawat for an excellent and a very enlightening session. I would like Dr. Taneja to please introduce the next session on research and biostats workshop.
Good evening, everyone, and thank you, Dr. Thulud, for this wonderful presentation. We move on to the next very important workshop on research and biostats. And for this, I invite the chairpersons, Professor Usha Datta from PGI Chandigarh, Professor Govind Makharia from AIIMS, Dr. Ashish Kumar from Sir Gangaram Hospital, and Dr. Mithun Sharma from AIG Hyderabad to start the proceedings.
Thank you so much, Dr. Sunil. It was wonderful to listen to the case description in the past session. So moving on to another important session of Inasl. Just to remind you that Inasl has conducted a series of lectures on research methodology and biostatistics almost 1 year back. And catching from that, this is a 1 hour session, relatively very short, but 3 very important topics and 3 very eminent speakers. The first, in this short session of 1 hour, we'll have 3 topics. Number 1 on how to do meta-analysis. Second would be conducting observational studies. And thirdly, a very important, very important clinical topic, survival analysis. And we have 3 great speakers today, starting with Dr. Anand Kulkarni from AIG Hyderabad. Then we have Dr. Madhumita from PGI Chandigarh and Dr. Rakesh Agrawal, Rakesh Agrawal from Jipmer in Pondicherry. So starting with the first topic on conceptualizing the meta-analysis, the stepwise step, and we look forward to hear from Dr. Anand Kulkarni. Dr. Kulkarni, please.
Thank you for your kind words, sir. Thank you for your kind words. Good evening, everyone. At the outset, I would like to thank the organizers for giving me this opportunity to discuss about concepts doing meta-analysis, stepwise approach. Also, I'd like to congratulate the whole team for the wonderful organization of the Inasl 2021. Without wasting time, I'll be touching upon definitions, why to do a meta-analysis, who can do a meta-analysis, what is perform analysis, how to search and perform meta-analysis, and how to assess study criteria and what to report. A systematic review attempts all available empirical research by using clearly defined systematic methods to obtain answers to a specific question. A meta-analysis is a statistical process of analyzing and combining results from several studies. What we do a meta-analysis? Each trial or study usually reports different p-values, and this leads to a conflicting reports. Conflicts, there is unclear evidence whether to be used in clinical practice or not. Size of each study and compute the summary effect provided p-value. If you see the chart is the quality of scientific evidence. Randomized controlled trials are at the top. Then we have this well-controlled analysis, which can also be a part of clinical practice guidelines. Such analysis is albumin infusion patients undergoing large volume parasitosis, which has been a part of the many multiple guidelines. They reported that there is decrease in PSCD by almost 60%, and this has become cited almost more than 300 times and is a part of clinical practice as well now. It is required to perform meta-analysis. You should first need to frame a question. It should be timely, clinically relevant. Most can be from your routine practice as well. Then you the population, the intervention you want to assess, a comparison group or a control group. Goal is to avoid unnecessary duplication, allow better clarity around the.
Dr. Anand,
and collaboration assisting.
Dr. Anand, sorry to bother you. We are not able to hear your voice very clearly. At least myself and Dr. Rakesh Agrawal are not able to hear clearly. What about others? I'm not sure. But if you can come closer to your mic and then.
If you switch off your video,
switch off the video.
If you switch off your video, things will become better. Dr. Kulkarni?
Yes, sir.
Switch off your camera.
Stop video. I think it's a network issue at your end. Dr. Anand.
Okay, go ahead. I think, but just switch. Yeah, that's
go ahead. So we need to register our reviews. Basically, we need to register on the Prosperous International Registry, where most of the systematic reviews and meta-analysis are registered. And major journals usually go through Prospero before taking an article for proceeding ahead with these articles. There are minimal set of data set required for registering a systematic review. You need to have the PICO, as I said before, participants, interventions, outcomes, and studies, the search strategy which you will be planning to execute, and also methods used to assess the risk of bias, method of analysis, the anticipated start date, as well as the source of funding and date of registration. Who can do a meta-analysis? Actually, anyone can do a meta-analysis. Basically, advantage of clinician doing a meta-analysis, he knows better about the disease and the clinical outcomes may be more well defined, but may find a difficulty with statistics. Advantage of biostatistician doing a meta-analysis, he is strong about statistics in writing the methods involving clinical studies and trials. And who should perform? A team of clinicians and biostatisticians will do a great job. When we first tried to submit a major COVID-19 meta-analysis to a major journal, it was reverted back after around 2 months saying that the field is rapidly moving and the study is out of date. So you need to be fast, you need to be in days. We analyzed more than 100 articles in this, and this article has been quoted more than 60 times till now. And I'm thankful for the team for providing, making a great team now. So the team is therefore required for performing a meta-analysis. Good meta-analysis requires a great team. You also require softwares. Comprehensive meta-analysis is one such software, which is a paid software. Review Manager, RevMan is a free software. Stata, SAS, R, and MetaExcel are also some software which can be used for meta-analysis. So you have a question, you have framed the PICO, you formed a group, you registered the review, you are ready with the software. Now you need to search and perform the meta-analysis. Basically, it's freely available. Google search, the hand search is also freely available. Google Scholar search. Conference proceedings in the previous 2 to 3 years before proceeding with the meta-analysis. Embase is a Elsevier-based search engine which requires registration through your institute or some hospitals. And most of the articles on Embase are usually on PubMed. Briefly describing how to search on PubMed. In PubMed, when you go there, you have an advanced button. You click on that. The next page which pops up is Builder. You then enter here you enter the mesh terms. Basically, all the meta-analysis will be based on your mesh terms. What is mesh? Mesh is basically medical subject headings. These are labels assigned to each article in the medline in order to describe what the article is about. This is done by trained National Library Medicine employees. They are known as indexers. They read each article added to the medline each day and assign to it about 10 to 12 labels which best describe the content of the article. If you are unsure what term to be entered on the website, go and check on the mesh terms website. You can find out the year of introduction. You can find out what actually is there in each of these headings. Like for acute and chronic liver failure, when we tried to perform a meta-analysis, we found that the year introduction of only was 2015. So articles before that will be missed in PubMed. You need to also do a Google search before proceeding with meta-analysis. For example, we did a search on COVID-19 vaccines and liver diseases. We found around 13 articles. You can easily convert them into your EndNote or any citation manager by clicking on the Send To. You can select all these articles and all these articles will be present in your EndNote. You can easily cite them. You can easily read them. It is easy for you to write the meta-analysis at later stages. You can create folders of articles included and excluded in this and then proceed to the meta-analysis. But search strategy should not be exited from here. You need to save it. It has to be submitted for publication. When you go to the advanced search in PubMed, again, you find that there is a history of search details. You just need to download this from the Excel. It downloads in the Excel sheet, and this is stored and submitted at the later stage for publication. So from PubMed, you search, you select what you want to include. I prefer to write it in a book or a Word document to outcomes which we want to usually try to divide the work between the teammates so that it's easy for the meta-analysis to be performed and it is more easier and rapid. Then we cross-check the data before analyzing the data. The software you chose, either comprehensive meta-analysis or Ravman, you enter the data from the Excel sheet into software. This is a comprehensive meta-analysis software where you have the study name, the event rate. You can either enter the event rate or the events or the incidence, what is known as incidence of injury or incidence of mortality, and the total number of patients in that group, and the total number of events in the control group, and the total number of events in the group. We can express the data as risk ratio, odds ratio, or mean difference. Run the analysis. What we find is the forest plot. This is basically the forest plot. We have the study name. We have the risk ratio here, the lower limit, upper limit, p-value for this. Here we can see that the p-value, the confidence interval is so wide that it is crossing 1. So it is insignificant. Whenever the p-value is less than or 1, it is significance value of 0.05. In this, we found that there is significant incidence, significant decrease in acute kidney injury by using terlipressin in patients undergoing liver transplant. We can also give the number of patients included here. We can also give the events rate here, and control group also. Similarly, we can give the number of patients and the events. The summary effect is given by a diamond shaped, whereas the each study effect is given by a square. This size of which varies with the weight assigned, and the weight is dependent on sample size. Greater the weight, greater the sample size. We always prefer to express the summary effect as with the random effect model and distributes the weight equally among all the studies. It accounts for within and between studies heterogeneity. And the summary effect is usually a mean effect rather than the common effect as given by the fixed effect. And the summary effect is more generalizable in the random effect rather than the fixed effect. Then we test the heterogeneity. If you see a forest plot, below that we have usually these numbers which have been written over there: chi-square or I-square, DF, the degree of freedom, the Q value and P value. What are they? Basically, Q is measured. It is a complex formula which depends on the study weight, effect size, summary effect, and the number of studies. It is measured effect size. And Q minus DF gives the heterogeneity. It should be less than 0. Here we have 2.14 minus 3, that is minus 0.9 around. It is less than 0, and the P is insignificant. There is no heterogeneity in the study. DF is basically degree of freedom. It is the number of articles minus 1. We have 4 articles minus 1 is 3, so DF is 3. The other ways of measuring the heterogeneity is chi-square, which is commonly used. It is described by Higgins initially. It moves in tandem with the Q. It is dependent on the formula known as Q minus DF whole divided by Q into 100%. It's given as a percentage value. Less than 25%, we consider it as homogeneous data. More than 25 to 50% is considered as moderately homogeneous data, and more than 50% is heterogeneous data. If I-square or chi-square is less than 25%, the random effect model and fixed effect model tend to give a same odds ratio. The results don't change. So it is preferable to just mention that to give a random effect model rather than saying that if the chi-square is less than 25%, we use fixed effect model, and more than 25%, we use random effect model. So how to summarize the database? And we come to the summarization of the data. If we can also summarize it as odds ratio, risk ratio, or mean difference. When to use and what to use. The studies have reported mean and standard deviation and the sample size. There we have a pre and post changes. We present the effect size as mean difference. You can calculate as raw mean difference for variables such as age and albumin, which are standardized, or we can calculate a standardized mean difference for variables which are not standardized, and there is no there are different instruments which are used for the study in each study. Next, we assess the risk ratio. Risk ratio is for in the incidence of mortality or incidence of an injury. It's the ratio of two risk in a 2x2 table. Here we see that the risk of death in the treatment arm is 10 by 100, that is A by N1, and in the risk of death in placebo arm is 30 by 100. The ratio of these two is known as risk ratio. All these softwares tend to convert the risk ratio into log of this risk ratio and the standard error of this square. it is done, this part is everything is done by the software. You need not worry about this. You just need to enter the dead and alive or whatever the incidents, the rates and the events, the total sample size. These part need not be worried. These are done by the softwares. By B in this and C by D in this group, the ratio of these two is known as odds ratio. Again, the odds ratio is also given as a log ratio. The risk difference is usually used for population-based studies or large ecological studies where we have different baseline populations. It's basically the difference between the risk of these two is known as risk difference. What is the difference and which is better? Basically, what I meant is ratio of risk is known as risk ratio. Risk ratio is excellent tool for developing or predicting any incidence or mortality. Ratio of odds is better defined for incidence. When you give an incidence of a disease, it is better that you don't give a p-value, which has no value, no significance in that. The difference in the risk is based on the risk. It should be given as risk difference. The risk ratio and odds ratio will be converted to log values, whereas the risk difference is the raw data itself. There are certain bias in performing the meta-analysis as well. So we need to assess the funnel plot symmetry and quantify using the Eggers interval. We say visually, we say that it's symmetrical. This is not symmetrical. The x-axis is nothing but the log of your mean effect is the x-axis, and the y-axis is the sample size. Larger studies which have a major dominant effect will be at the center and at the top. Smaller studies will be selected around the lower end. And if the intercept is significant, that is p less than 0.1, we say there is significant publication bias. If the intercept is more than 0.1, we say that there is no publication bias. Next, we assess the quality of study. Cochrane risk of bias and Gerard score used for RCT analysis. Newcastle, Ottawa, NOS scale for case control and cohort studies. Appraisal tool for cross-section studies. And also, lastly, we have Institute of Health Economics checklist for case series. Quality of study has to be done for before submitting a meta-analysis. We also use sensitivity analysis based on the quality of study. Cochrane consists of these many things: selection bias, reporting bias, and other biases. Basically, there are separate domains which has to be given impartially, the judgment being whether it is high risk, low risk, or it is also dependent on the performance bias that you finally form a chart like this in your Excel sheet and give a summary effect. If you see here, the summary of this has to be mentioned in your article in the study quality. If you find the low risk of bias in all of them, just mention that most information is from trials at low risk and it is unlikely to alter the results seriously. Similarly, for unclear risk of bias, information is from the low or unclear risk of bias and might raise some doubt about the final results. High risk of bias, the bias is so serious that it might alter the results significantly. Lastly, we come to the Newcastle Ottawa scale, which is based on selection, comparability, and exposure. There are 9 stars. Each of these is given 9 stars. I don't want to go into the details because of lack of time. Total of more than 6 stars is considered to be a good quality study. For sensitivity analysis, we can tend to include patients into trials which have scored more than 6. Then you prepare the manuscript in accordance with the checklist. There are certain checklists provided by Prisma and Moose. Prisma is basically preferred reporting items for systematic reviews and meta-analysis, which manuscript has to have before submitting. And Moose is basically meta-analysis of observational studies in the epidemiology. So take home message, to perform a meta-analysis, you need to have a good question, clinically relevant question, prepare a PICO, have a good team. The search strategy has to be very strong. Meta-analysis is usually, once you are done with search strategy and making your tables and Excel sheet, meta-analysis is quite easy. And write up whatever you have done in briefly according to the Prisma guidelines. The flow chart of your Prisma and methodology carry a significant weightage when you submit to major journals. Lastly, I would like to thank my teammates who are the backbone of our meta-analysis, and my Professor P.N. Rao, who is my mentor and who was the first person to instill the idea of performing and doing meta-analysis and gifted me a book on meta-analysis. Thank you.
Thank you so much, Dr. Anant, for a wonderful talk. although we had some audio disturbances in between, but we could go through your lecture. It was wonderful, pointed, point-wise, stepwise, and I'm sure many of us would have a benefit from this lecture. So let me ask the question that you, and Dr. Assis, do you want a question now or at end of the session? What do you suggest?
I think we can
Yeah,
have
go.
it. Sorry, the audio is not clear. I think we can have it now because the topics are different. So after each lecture, we can have 2 minutes.
So, all right. So I don't find any more questions from the audience, but maybe I start the ball rolling and look forward to other chairpersons to add on. That there have been trend of increasing number of meta-analysis from our own country. And that's a wonderful step, not only in gastroenterology, but in pediatrics, in cardiovascular disorders, diseases. The number of meta-analysis have been being done last 5 years. That's a positive change. With that, maybe I invite Dr. Assis, Dr. Musa to make comments. Dr. Mithun is there, or anybody, Dr. Madhumita and Dr. Agrawal.
I have only one
Basically,
comment.
we feel meta-analysis is easy. Sorry.
No, go ahead.
So please.
So I just wanted to say that although the number of meta-analysis has gone up, but one thing we have to make sure is that what we include in the meta-analysis, the quality of articles which we include, because it's all like GIGO effort. If garbage in, then garbage out. So if the quality of articles which we include in the meta-analysis has to be very good. So I would put a special emphasis on the quality, like Dr. Anand had also mentioned, that we should check the quality, and if they are only of high quality, then only we should include.
I would like to make a comment here. There is a lot of meta-analysis coming on in literature, but the issue is that meta-analysis impacting your understanding about the disease or changing practice? A lot of meta-analysis are coming up as just one more publication for a person, which I don't think is sufficient enough to impact the science component of it. So I think a meta-analysis is a huge exercise, especially if you do it the Cochrane way. And that is the most meticulous way to do a meta-analysis. It should be done if it is going to give an answer to a specific question for which we do not already have an answer. Just to say at the end of it that there are very few studies and we should do more studies cannot be an adequate conclusion of a meta-analysis. So a lot of effort should go in a direction in which is going to help science.
Any comment, Madhumita, or we go to
what is the main limitation of a meta-analysis? For example, can it data which is taken from again the population needs to be concerned. Applying it to Indian practice is going to make so just taking data from all over the world. So the generalizability to a single population should be the same as with any interventional or observational study.
So if the classical example would be the use of ivermectin for COVID, which has been based on a meta-analysis recently. And as it turns out, most of the effect in that meta-analysis was based on one large Egyptian study, which people have realized had such infirmities that it should have been picked up by the person doing meta-analysis. And that study has finally been retracted, making the results of the meta-analysis unviable. And based on that, the whole world, especially in our country, a whole lot of people haven't realized that the original study was really not worth it. And that's, I think, what tells us. So meta-analysis is a great tool. To go with what Usha said, if you have 5 studies and all of them show that the effect is positive, again, there is no point in doing a meta-analysis. So Dr. Kulkarni said very correctly what he said, but I think what really needs to be looked at is not that this is an easy way to publish something. We really need to look at whether it is needed. So this is a slightly different kind of session, so we are commenting rather than asking any questions. And that's something that we need to keep in mind. Thank you.
Right. With that, we thank Dr. Anand for a wonderful talk. And in interest of time, we go to the next talk. Maybe Dr. invite Dr. Usa to Continue to the next speaker and the topic.
Yeah, thank you, Dr. Govind. It gives me great pleasure to invite Dr. Madhumita Prem Kumar, who is a close friend and an associate at PGI Chandigarh. She is presently an associate professor in the Department of Hepatology. She'll be speaking to us on designing and conducting observational studies. Dr. Madhumita, please.
So I would like to thank the organizers for giving me the opportunity to present this talk in the presence of my mentors, from the people who have actually taught me biostatistics. So I'm very grateful to have my mentors in the audience. So my talk is about designing and conducting observational studies. And I have no relevant disclosures. So when we are coming to analytical studies, and we pretty much go into two arms: experimental, where we are actually having some kind of intervention, and observational, where we have this kind of where we have essentially where there is no intervention, but we are trying to observe the effects of an exposure and development of disease over time. So when we are designing a study, we need to know what is the objective of the proposed study, translate these objectives into a testable hypothesis, and define our research question, list the possible outcomes and resulting conclusions, and all of this should be taken over time. So ideally now we also need to realize in COVID-19 times that there is an ideal question one could pose, and then the data that is feasible to collect or access. So what is the research question versus a hypothesis? An example is, how does carvedilol, the use of carvedilol, affect development of refractory ascites? So that's my research question. But the hypothesis that I'm testing would be, in patients who are treated for bleeding or secondary prophylaxis using carvedilol for esophageal bleeding, those with low cardiac index are going to have poorer diuretic response than those with preserved cardiac function. So my hypothesis is going to be testing the change in the cardiac function of patients who are on carvedilol, and then use that to determine whether they'll have worse outcomes vis-a-vis diuretic response. So in the classification of study design, when we are looking at observational studies, these could be simple descriptive analysis or case series. They could be a prospective cohort, a retrospective cohort, cross-sectional analysis, which is a prevalence survey, and a combination of prospective and retrospective cohort. So the meta-analysis section has already been covered. The studies need to be feasible. For example, I cannot design a study in which I need to take observations very early in the admission of the patient, because we are generally waiting for COVID reports, or patients are having a delayed presentation. So it should be feasible. It should be interesting enough and not just added on for the sake of adding another publication to the CV of the investigator. It should be novel. It should be ethical. So just observing someone without treatment, for instance, in a control group is also unethical. And of course, it should be relevant to current times. So after we identify the research question, we design the correct hypothesis, and then we choose the study design, in this case observational. We have to calculate the correct sample size. Otherwise, there is no point conducting the study. We write down the research protocol, get ethical clearance, and register the trial. Even observational studies have issues, so they need to be registered so that we know that the researcher has carried it forward in a prospective manner, and the exact time protocol needs to be maintained. Why do we need observational studies? Because we cannot have interventions always. They may be inappropriate. If we are looking at the exposure of smoking or the exposure of radiation to certain disease outcomes, it would not be appropriate to do an intervention study. And in cases of rare outcomes, again, we cannot be subjecting patients to exposures to look for very rare outcomes. So the PICO and PICO-T is really important. We need to know the population and the generalizability of our results as an internal and external validation. We need to define our exposure or the factor of interest. We need to get a comparator. It is not useful to do just an analysis on exposure alone. We need to have a comparison group, and the outcome that are clear primary and secondary outcome measures and time span in which it is there, it should be clearly defined. The effect size has to be defined at the outset. So it is important when designing an observational study, be it going in from a clear, simple case report to the case series, cross-sectional analysis, and prospective cohort study, the complexity and validity and impact would increase. Now, what is a cohort? I first heard this word from Asterix and Obelix, where a Roman cohort was an individual company, a company of individuals of around 480 members. So if we look at the observational study design, and we look at the exposure, and we are trying to identify which exposure actually led to the disease or no disease, then this is a case control design, because we are trying to identify the exposure which has defined. So we already know who is disease and who is not, and the researcher is there already at the end of it. In a prospective cohort, we have people who are exposed and not exposed, and we follow them up over time and then look to see whether they develop disease or no disease. So a cohort study is different from a case control study, and we'll come to that. The difference mainly comes in a retrospective cohort. Again, we have a full population of individuals in whom disease has already occurred, but we are trying to trace them back in time by identifying who in this population who will develop disease after an exposure. So there's a subtle difference between a case control and a retrospective design. So coming to a prospective cohort study, we know that there is a population who will have some kind of exposure to the risk factors, for example, beta blockers or no beta blockers to development of bleeding or ascites. If we have HPV therapy versus none, and whether they develop HCC, vaccine or no vaccine who develop COVID-19. So after exposure to the risk factor, the identification is whether they develop disease, yes or no, in each of these arms, the ones who are exposed to the risk factor to the ones who are not exposed. And we develop a ratio called the risk ratio or the relative risk. In a retrospective cohort, as I explained, the population exists. It's all mixed up. We know in the ACLF ARC database, there is a huge population of individuals that has been recruited over time. And we know some of them have certain disease factors and not. Let us take sepsis or no sepsis. So this is a mixed population. I have their database. And then I go back in time to see whether they had a high CRP or procalcitonin, and I actually test their samples. I don't ask the patient. So this is not a pre-planned study, but we have ethical clearance. These are biobank samples for which we have ethical clearance to perform additional academic analysis, and we follow up from a complete population after the exposure. For example, if I have a hypothesis that a combination of hsCRP and procalcitonin will predict patients who develop sepsis or no sepsis in this population of entire ACLF ARC, then this is going to be a retrospective cohort design, because the entire population is going to form my denominator. Let us compare why this is better. Cohort studies are useful where randomization is difficult, because we are obviously not going to randomize high procalcitonin to low, where there are multiple exposures and multiple outcomes, where there are rare exposures and rarer side effects. The disadvantages, of course, since the time is involved, a lot of follow-up is involved and attrition is possible. So researchers tend to see whether a case control would suffice, but prospective data is obviously going to yield the best advantages. Now, in a case control study, please note there is a subtle distance. We don't have an entire population. Suppose from the ARC ACLF cohort, I just select individuals with fungal pneumonia and individuals without fungal pneumonia. So we are not having the entire ARC database here in the denominator. And then I go back in time to see how many of them receive steroids for, say, alcohol-associated hepatitis. So we are studying the exposure to steroids here, and we are taking two separate groups who have an ultimate outcome present. So this is an example of a case control study. So cases versus controls need to have similar risk. This is a population-based cohort, and this is a case control study. In either case, they need to be adjusted for age, sex, comorbidities to make comparison easy. So a control group is essential, whichever way we are looking at it. So in case control study, we are going back retrospectively. The entire population is not part of the denominator. We have two separate groups, one disease and no disease. And we are looking at the exposure to the risk factor, yes or no, in the diseased individuals. We are looking at the risk factors, yes or no, in the patients without disease. So the same risk factors, say smoking, in developing lung cancer. And the focus here is actually on exposure, because we have two separate groups. at the beginning of our study. So this is a case control study. Whereas in a retrospective cohort, and I'm repeating this again and again, because this is important, we have an entire population of mixed individuals, some of whom are diseased or not diseased. So disease has already occurred. But here we are focusing on the outcomes based on our hypothesis that exposure to a certain risk factor, say steroids, precipitated fungal pneumonia later on in the entire cohort of patients who are in the ARC-ACLF database. So if we are looking at time and research, a cross-sectional study will just look at a slice of the population and define what are the risk factors to develop a certain kind of disease. Say the cross-sectional analysis of COVID-19 seropositivity in a set of individuals in Chandigarh city. A prospective cohort will actually follow them up into the future. Retrospective and case control study are similar, but difference is in the denominator. The entire population is a denominator in retrospective, whereas case control has two separate groups. In both cases, we are looking at exposures in the past, but in case control, we are trying to define the exposure. In retrospective cohort study, we are trying to look at the exposures in the past and to see whether they develop disease in the future. And then we have the RCTs, and of course, the time would be in this way. Case control studies are very cost effective and they require a short period of observation since we have smaller groups, and they are useful for rare diseases, but they are subject to bias because we will be selecting the two groups. And of course, causality interpretation is next to impossible with many confounders that could be there. In a cross-sectional study, we take a representative sample. Say, for example, I might take, if you are looking at the COVID-19 seropositivity, I take representative samples from various districts in Chandigarh city, and I actually see whether they are having seropositivity for COVID-19, yes or no. So this is a cross-sectional analysis. Now, this is a very important concept, the relative risk versus the odds ratio. So the relative risk, for example, it can only be done in a cohort study. So if we are looking at the development of HCC, in a patient who is having hepatitis B virus, yes or no. And we know that if hepatitis B is there, HCC is more likely to develop. So we are having a population of individuals of 20,000 people, 10,000 have chronic hepatitis B, 10,000 do not. HCC develops in 100 in the first group, 10 in the second group. So total number of HCC is 110. This is the classical table, contingency table. So the relative risk is going to be the incidence among the exposed by the incidence among non-exposed. For example, in this case, it is going to be 100 by 10,000 divided by 10 by 10,000, which is 10 times. So in a cohort study, if we look at the denominator, it is the entire population. The odds ratio is the odds of developing HCC the way a gambler thinks. So odds of developing HCC in HPV, whereas the odds of developing HCC in no HPV. So that's going to be 100 by 9,900 as odds, by 10 by 9,990. So the entire population is not in the denominator. This comes to be 10.09. So odds ratio tends to overestimate. Odds ratio is used in case control studies. It has less validity as compared to cohort studies. And whereas in cohort, we can use either. So I hope that explains the thing. So it is comparing a slice of pizza to the whole pizza, whereas a slice of pizza which has pepperoni on it towards the other slices of pizza which are not having pepperoni on it, to make a very simple analogy. So cross-sectional studies, of course, have great advantages when we are looking at multiple exposures and multiple outcomes. And of course, we cannot get causality. We just get prevalence of disease. We get some idea about exposure to outcome, but we require large sample sizes and good quality stratified sampling in some cases. And when we come to the lowest level of observational study, which would be case studies and case series, which have some value when we're looking at very rare complications. For example, rare side effects of the COVID-19 vaccine. But confounders are that the patient may have had COVID-19 per se. So whether the disease, for example, PBT has been reported in patients who have received vaccine, but whether it is attributable to the prothrombotic state in patients who have had subclinical or clinical COVID-19 versus vaccine effect. remains to be seen. So case studies and case series have very sound limitations, but they do present ideas for future research. Ecological studies are the next kind of observational study where we are looking at data at the population or group levels, so which means it can apply to an entire population rather than applying it to an individual alone. We use aggregate or surrogate means of exposure, for example, the Framingham Heart Study, and in certain occupations like miners or asbestos factory workers, if we are looking at outcomes, then that would also be an ecological study. Air pollution is another, but they are subject to fallacies. For example, we could have high amount of fatty food intake in miners who are given a certain diet, and we attribute the development of CAD to asbestos. So there are ecological fallacies, which I encourage students to read more about. Confounding, I will very briefly cover. Lung cancer and is generally causally associated with smoking. But if we look at studies, there is a confounder, which is alcohol. So there's a spurious association of alcohol with lung cancer. Confounding needs to be assessed. Confidence intervals, the larger the sample size, the more confident we are that there is a precision of the estimate of association between exposure and outcome. So a 95% confidence interval is what we generally use. The more the width of the confidence interval, the less chance that the association of exposure to outcome is there due to actual causality of disease. Very briefly about random error, which comes in as noise in the system, which is due to variability in the selected population. Random error can be reduced by taking a larger and appropriate sample size. Bias is not prejudice. Bias is a systematic error that creeps into collecting information. Dr. Kulkarni covered it about meta-analysis. So bias can come in, for example, if I'm comparing the racing speeds of dogs from Germany, but I recruit cohorts which are Chihuahuas versus German Shepherds. And I don't know that I label them all as dogs. So that's a very rough way of saying a bias is coming in due to the inherent characteristics of the groups. So another example, the risk of CAD when you look at body size and risk of myocardial infarction. So bias can come in a systematic way. The way to reduce the bias is to have a larger study, and it tends to change the estimation of a true association or effort. So very briefly, to summarize, we have to spend a good amount of time on existing literature so that we don't repeat what has already been done, discuss with as many colleagues as possible, because that really gives good inputs as to exposures or outcomes. We have to reduce bias. The study hypothesis should be objective, and only if we get a correct protocol are we going to have correct results. I cannot emphasize enough the importance of PCOT-E, where we look at the population, intervention or exposure, a good control group, outcomes, association of causality, and confounders. So I have covered in a very brief period. I have really rushed through, but I'll be happy to take any questions, and I'm willing to share my slides.
Thank you, Dr. Madhumita, for an excellent presentation, and you have covered a lot of ground on research methodology as well as study designs. Very well done. I would just add to this that there is one more component of a nested case control study, that within a cohort study, you go back and pick up two populations. The reason I'm saying this is that it's a very efficient study design. And what I would also emphasize to the students is that whichever disease you're interested in, start maintaining a cohort, keep the data of those patients, so that, and also biobank that samples, and also take a consent for the present research and future research, so that you can then follow. It may be hepatitis B, it may be HCC patients, whatever it may be. Just start collecting a cohort and have a good case report form in which you can enter your data in and keep your data maybe with an electronic database system. Thank you, Dr. Madhumita, for a wonderful session.
Two questions. Number one, that odds ratio and relative risk. So we are all conditioned, and we don't really understand the pizza, one pizza out of that whole pizza. So can you say in layman terms for most students to really understand what is odds or what is, because we as the doctors, we always use risk ratio or it's much more easy to understand, tenfold higher. But tenfold higher, does it mean tenfold higher also about odds?
So odds ratio is generally used with case control studies. It has less of relevance. So it is just the increased rate of disease. So the odds is like the odds on a horse winning a race. So that's actually a term which is used by gamblers. So we have the odds of winning a certain race 5 times as much for horse number A and 3 times as much as for horse number B. So the denominator, or in when we are talking about clinical studies, it is the risk of developing a disease in patients who are exposed to smoking, say lung cancer, and in the risk of developing disease who are non-smokers. So the two populations which are part of the denominator are entirely discrete. So odds is going to just give a rate of increased risk of a disease in with a certain exposure. Relative risk is actually going to take into account a lot of other factors. So the entire population comes in the denominator, and it is a risk of actually developing the disease in smokers when followed up over time in the entire population, not just discrete cases with disease and controls without disease. So the relative risk is going to give a better causal association of developing a certain disease when followed over time in the entire population. The pizza analogy I have stolen quite obviously from Dr. Usha Datta, because she uses that to explain to the students that if you are picking up one slice of pizza and comparing it with the rest of the remaining pizza, then that would be the odds ratio. And when we are looking at one slice of pizza with the entire pizza being the denominator, that would be the relative risk.
No, it's not only pizza, the apples also, many times. So again, I mean, I think time will not allow to ask more questions. Maybe Dr. Usha will take it forward. Or
Thank you. And if there are any other questions, I can't see any in the chat box, but I'm sure the recorded lecture will be listened to by many students right now and as well as later on. And Dr. Madhumita is available on email to clarify further issues. So what I would again really emphasize for all the students who are there is to spend a lot of time in finalizing your study question and choosing an appropriate design for that question. Though cohort studies are always the best among observational studies, but every study has its own advantages and disadvantages, and based on the feasibility, we have to choose a particular study design. So more importantly, it is to choose to get your study question right rather than, and then based on the study question pick up a study design. So those were my two comments on that. I don't know whether Dr. Rakesh has anything to add to it.
Maybe we invite
no,
Ashish.
really nothing to add. You are
Ashish, can you invite the third speaker? And
Okay.
Dr. Mithun to close the session at end of it. Yes.
Sure. So it is my proud privilege to invite my guide, my teacher and my mentor, Dr. Rakesh Agarwal, who was professor at SGPJ and currently he's the director at JIPMER Pondicherry. He's needs no introduction, especially in the research methodology. He is himself conducted lots of research methodology workshops, and I have also learned a lot from him, like biostats and also computers, SPSS and everything. So over to Dr. Rakesh for his talk on survival analysis.
Thanks, Ashish. Can somebody confirm that you can hear me?
Yes, yes.
Yeah.
So, why do we need survival analysis? What is it? Very often as clinicians, we wish to know whether a particular treatment or a particular factor prevents or delays death or improves survival. This can be done using two types of data. These could be categorical or dichotomous or continuous. By categorical data, we mean we take a group of people, follow them, and see whether they die or survive. This is perfectly fine if you are dealing with children with diarrhea, because acute diarrhea, because within a week you will know whether they survive or die. But that's not the type of diseases we deal with. Very often we deal with long-standing diseases and we need to follow them for years. And if we have such data, we look at whether 5 years later in the treated group, there is a greater 5-year survival compared to in the group that is untreated. But there could be two groups with similar 5-year survivals, but in one, most of the people died by 1 year, and in the other, most of the people succumbed in the 4th year. And we would miss the difference. So a better thing seems to be, we look at time until death in the two groups, which means we look at mean survival. How many years or months do people survive, untreated or treated? But that means we need to know the time for each one of them. So we need to have everybody reaching the endpoint of death. That's again very difficult. That's not possible for us. And we need necessarily to deal with incomplete data. And therefore we need another tool, and that is known as survival analysis. I'll take you through the nuances of this within the limitations of time. So what we are doing in survival analysis is we look at each subject and we first see whether the person has reached the endpoint of interest or not. And if yes or no, we try to look at the time that the person has been observed for till either the endpoint of interest or another point which is called as the point of sensory. So this time has to be looked upon from a predetermined start time. For instance, the time a person is enrolled in the study, and endpoint does not necessarily have to be death. In survival, it could be this. But if we are doing a treatment for preventing variceal bleeding, the endpoint or could be not death, but could be the day on which the person has the next episode of variceal bleeding. If you are trying to prevent SPP, this could be time of onset of SPP. So why could a person not reach the endpoint? This could be because a person could be lost to follow-up, or because a person could be enrolled into the study at a different time and there could be a different follow-up duration. And let me show you a few examples. I'll skip this slide, that will be easier. Let us say we are trying to do a study and we are trying to see how good is injection Voveron to relieve abdominal pain in people who come with that symptom to our emergency room. And we are interested in pain relief within the first 2 hours or 120 minutes. I go to the emergency, the first patient comes, I give him injection, I ask him every 5 minutes if his pain is better, and in 30 minutes he has pain relief. Good, the drug has worked. In the second patient, pain relief occurs, but occurs at 45 minutes. In the third one, 120 minutes, my planned observation period ends, but there is no pain relief, so we can say failure. The fourth patient, at 60 minutes, he has not had pain relief, but a decision is taken to wheel the patient into the operating room. It is possible that he would have had pain relief between 60 and 120 minutes, but I have incomplete observations. But I surely know that the time taken for pain relief is more than 60 minutes, if at all. And I want that data to be included. The next patient, at 60 minutes, he decides to leave the hospital. There is a loss to follow-up. Another person, at 15 minutes, the patient is howling with pain, and my senior comes and decides to give the person a narcotic analgesic. So in these 4 cases, the data are not complete. We do not know the time taken for pain relief, and that is what is the concept of censoring. Their observation has been stopped at a time point before the event pain relief could occur, and therefore these people are supposed to have had their data censored. Let's look at another example now of a chronic disease. I have a patient where I'm trying to look at survival in patients with cancer. The first day I start the study, 2 patients enter the study. One dies at the end of 1 year. So he has had the event of interest. The second continues in the study for 4 years, and then my study funding comes to an end and I stop the study, but he's still alive. So I do not have complete information on him. I get the next patient entering the study 3 months later. He stays in the study for 1.5 years and then migrates to UK. 2 other patients join the study but die during the study, and another patient joins the study but is still alive at the end of the study. So if I look at each of them, their start points are different, but my start point has to be common. So I bring them all together. When I arrange them in the ascending order for which I could observe them, those with a red dot, I have complete information till the event of interest. And in the other 3 with blue dot, the data are censored for different reasons. And based on this, we want to draw a survival curve. We need to estimate the survival experience of the group, and we want to know at any given time what proportion can we expect would be living. Let us say we divide our time. Let's say we have a 6-year period and we divide it into equal time intervals. We start the study with 100 people. In the first time period or first year, 10 people are lost to follow-up, 9 die, so that at the end of the year, I still have 81 people. But I do not have complete data for these 10. I have complete data for only 90. So I know that out of these 90, 81 live. So the probability of survival in this period among those who complete this follow-up is 81 by 90 or 90%. These 81 people now join the second year. Again, some are lost to follow-up and some die. At the end of the time period, this is the number alive. 81 minus 21 is 60 is the number for whom I have the complete follow-up. So of those who enter the second year, 45 out of 60, that is 75% survived during the second period. So if I have to look at 90% survived through the first year, of those 75% survived through the second year. So overall survival after 2 years, if nothing had happened, would be expected to be 67.5%. Similarly, I can do calculations for future years, and I can calculate what proportion can be expected if nobody leaves the study till the end of 6 years. I can plot this either as dots or more often as a series of steps, and this is what is known as the survival curve. The time interval I took as years, but depends on the study. For the Wabaran study, it could be minutes. For a study on prevention of variceal bleed, it could be days or weeks or months, but it should be clinically relevant. It will depend on the study you have. Such analysis, which is also known as Kaplan-Meier analysis, makes some very important assumptions. Firstly, it is assumed that people who discontinue the study, people who are censored, if they had continued in the study, their survival would have been similar to that of those who continued in the study. It's a very important assumption and is very often not true. It is likely that people who have discontinued the study have done so because they have died. If that is the case, then their survival is much lower than that of people who are continuing in the study. On the other hand, these could be people who have been cured and therefore they have stopped them. So you really need to see whether people whose data are censored are any different from those who are continuing in the study. Secondly, when you have a study such as the cancer study I talked about, where people are enrolled in the study at different time points, it assumes that their survival would be similar. However, very often, in the beginning, in the trial, we are admitting patients only who are coming to us for a serious disease. As the study goes on, people come to realize that you are doing a study, people can get treatment for free. Milder cases start coming to your institution, and their survival probabilities may be very different. So one has to be very careful when looking at this study to see whether the censored subjects are similar to those or dissimilar to those who are continuing the study. If there are too many censored subjects, one cannot rely on the results of this analysis. The same happens when the sample size is small, or if you have large time intervals between events, if there are very few events. So how does one look at a survival curve? I could look at 1 year, draw a perpendicular and go like this. I can find out what is the 1 year expected survival, what is the 2 year expected survival, or 5 year expected survival. Secondly, so this gives us a cumulative survival. On the other hand, if one looks at this part of the curve, we can know what is the cumulative mortality at any time. The slope of the curve tells us what is the risk of mortality at a particular time point. So if we are here, the curve, there would be a bigger slope. So risk of dying is much more in the first year than it is at year 6 or 7. The final part that I want to talk about is how do we compare survival data in two groups. The method we use is something called as Cox proportional hazard analysis. So if these are two curves that we have, one group shown here in red and the other group shown here in blue, we kind of smoothen them into curves. When we smoothen them into curves at any time point, we can find out the risk of dying by looking at the slope. And so that gives you over a 1 year period or 1 unit of time, what is the probability of dying in one group versus in the other group. And this hazard of dying, if we take the ratio, we get a hazard ratio. However, this will vary along the curve. The hazard ratio will be very different at different time points. So what Cox proportional hazard ratio does is, it looks at hazard ratio at each time point and integrates them into one estimate, one value, and that is what is known as Cox proportional hazard ratio. If the ratio is more than 1, that means the group has a greater hazard of dying or a greater risk of dying. So to summarize, survival analysis is used when we are interested in time from a particular time point till some event of interest occurs. This is usually survival, usually death, but can be something different. It's a very sensitive tool. It is better than the yes-no analysis because in yes-no, it is possible that 5-year survival is similar in two groups, but still in one group, most people died earlier than in the other group. We use a Kaplan-Meier method, which I have tried to demonstrate to you. However, this analysis has a limitation that it makes very important assumptions, and those must be fulfilled for the results to be valid, but are very often not true. And if you need to compare two groups, then you need to use Cox proportional hazard method. I can be pretty certain that many people would not have understood everything because I have limitation of time and it's a difficult topic. My idea was to get you initiated. Go ahead on the internet. There are very good learning tools for this. Consult those, and that should be much better than what I have been able to do. Thank you.
Thank you, Professor Agarwal, for that wonderful session. As they say, a good teacher always stimulates. So you have stimulated maybe many of us to go back and read on the topic. I don't see any questions in the chat box. It was actually a very wonderful session, starting from Dr. Anand, who was my colleague, and I never knew about meta-analysis can be done so easily by the steps he explained to us. But yes, we kept in mind the comments from the co-chairpersons that a meta-analysis should not be done just for the sake of it. It should be path-breaking or changing our practice pattern. We had a very interesting talk from Madhumita, where her examples of how to do an observational study was very well taken. And she gave us insight into, because we find that many people just write in their paper as a case control or a cohort without knowing what the difference is. And it's very important that we know what study are we doing. And it's important that this study reach a reasonable outcome. And finally, survival analysis. This is something which from the patient's perspective, from the family's perspective, when we tell them about statistics, the first question they ask is, doctor, what's the risk? I do a RFA for ACC. They ask me, doctor, what is the risk of him dying? Or what's the risk of the tumor recurring? So survival is something which is very important when we talk from the outcome point of view. Something which does not change the outcome usually is not considered to be as great a treatment option as something which can change the outcome as survival. With this, I think because of constraint of time, we are already overshoot by 5 minutes. I would like to thank all the speakers and my co-chairs for this wonderful session, and thank INSL for including this topic, which is very rarely discussed, but is something which is the key to getting more publications worthwhile from India. Thank you so much. And yeah,
please. The Assis had some point to make, and
okay. I can see that. Yeah, sorry. Yeah, Dr. Assis, please.
Yeah, just a quick question. We often see log rank test in survival analysis. So just you can, for the benefit of.
Log rank test is another method. It is simpler to do, but then today we have computers, so either is possible. Cox proportional hazard analysis is much better. Is much more often used. But yes, log rank test is another test that can be used.
Usa had last question.
Yeah, very quick questions. Really enjoyed your lecture, Rakesh. If we have the time interval shorter, we will be able to capture more data. Suppose the thing is about 1 whole year, we may be losing a lot of patients down the line. So does shortening the time interval improve our quality? And the second thing is, what percentage of censoring is acceptable? Because quite often in various studies, I find a whole lot of patients are censored and yet they go on to report the data.
So Usha, I showed that kind of calculation using a table. I divided it into only 6 rows. Of course, if you have data for people accurate to the last month, you could have made 72 rows with computers. It's absolutely possible. Or for that matter, if you have death data for everybody up to the last day, you could have 365 into 6 rows, 1 for each day, and your curves will be much more accurate. And that is exactly how it is done. This was only a simplistic representation, so I took a year as the unit. The second question that you asked was, sorry?
How much censoring is acceptable?
So that depends. First of all, ideally there should be, it depends, censoring could be for various reasons. So if I am following up patients with liver cirrhosis, they could be censored because they stop coming to me, because they undergo a transplant, so they are no longer having cirrhosis, or because my study comes to an end. If there is a large amount of censoring, if 70% people are alive at the end of the study and they are all censored on that day, that's entirely accepted. That's not, main thing is for what reason people are being censored. So that reason should not be because they have stopped coming to you. Secondly, if you have 2 groups, then censoring should be similar in the 2 groups and for similar reasons. I hope I'm clear.
I think we can stop here, and I think thank all the co-chairpersons and all the speakers for the wonderful talk in this session. So I think we hand over to Sister Organizers, please.
Thank you all for this wonderful session. And before we move on to the last session of the day, I have a small announcement to make. The valedictory function will start at 9 o'clock in Hall A. I would request all the speakers to stick to the allotted time. So moving ahead, we have a very interesting session now. This is the Inasl Task Forces session and the highlights of the recent guidelines. For this, I invite the chairpersons, Professor Ibrahim Koshi, Professor P.N. Rao, Professor Rakesh Agarwal, and Dr. Anil Arora to invite the speakers. So,
Ram, you are on mute, sir.
Muted, sir. Muted, sir.
Yeah, I think welcome you all. I think Dr. Professor Koshi, are you there?
Sir, I don't see him. He's
okay then. I think we have had a lot of sessions on this particular, all these issues for the guidelines. And of course, first I would request Dr. Pankaj Puri and Dr. R.K. Dhiman combo for nutrition in the clinical liver diseases. Dr. Pankaj, please go ahead. Thank you.
Thank you, sir. I'll just share my screen and I hope you can all see my screen now. And Dr. Dhiman is also here. And in fact, Dr. Dhiman was instrumental in conceptualizing these guidelines, and some of our chairpersons, including Dr. Arora, were all part of formation of these guidelines. Now, this is a big 50-page document, and it's not possible for me to cover everything. And we'll just show some of the highlights of the guidelines which were published. We needed guidelines for nutrition in chronic liver disease, specifically for India in chronic liver disease. The importance of nutrition has been well recognized. There have been many guidelines from other authorities like the Inasl and the ESPN, but these guidelines cannot be universally applied to the Indian population. There are many specific issues that merit consideration in assessment of nutritional status and management of malnutrition in the Indian context. And just to show a few, we have a very high prevalence of malnutrition in India. There has been a lot of progress in health and nutrition interventions in India, but we still have a huge amount of malnutrition load, especially in rural India. The tribal population is also particularly vulnerable because of geographical isolation, uncertainty of food supply, lack of adequate healthcare facilities, and irrational belief systems and taboos. So keeping all these things in mind, and also some other issues were that Indians have a very lower muscle mass and a high prevalence of sarcopenia, where a health survey conducted across many countries, including India, between 2007 to 2012, showed that the sarcopenia in adults more than 65 years of age was the highest in India and the lowest in Poland. Overall, South Asians have a much lower muscle mass compared to Aboriginals, Chinese, and Europeans, and about 15% lower mass compared to the Western population. There is sparsity of Indian normative data. Some data has been created, including some from Dr. Sidhu, but we need further data and further studies to confirm the same. Also, Indians have much lower exercise. We are basically a little lazy group of people. We don't exercise enough. So with all this background, a task force was conceptualized by Inasl, which was headed by Dr. Dhiman and some of the leading people, including Dr. Anand, Dr. Anil Arora, Dr. Acharya. And we also had a couple of leading workers who've done work in nutrition and chronic liver disease, including Dr. Punita and Manuela Murley, who were all part of this task force. And this went through many rounds and presentations before we came up and made the final document. So I will just highlight some of the few statements, and it's not possible to do it all. So prevalence is much higher compared to the global population, ranging about 47 to 84%. It worsens with worsening liver disease, and it is associated with increasing decompensation, infections, and waitlist mortality in patients with liver disease. Also, post-transplantation, people who have malnutrition and sarcopenia have poorer outcomes, and some patients may develop sarcopenia even after transplantation. We all worry about malnutrition, but obesity is also an issue, especially in the presence of alcohol, and may cause worsening of fibrosis in people with liver disease because of other causes. The basic nutritional requirements are about 30 to 35 kilocalories per kg per dry body weight per day, and the protein intake of 1.2 grams per kg per day, which would go up in the presence of malnutrition to about 1.5. The carbohydrates should account for about 50 to 60% of the calories, and the fat should be 20 to 30% of the calories. Who needs nutritional assessment? People who are obviously malnourished or who have a high risk of malnourishment really don't need any assessment. These would be those who already have a low BMI, a very high BMI, or those who are child sick. Every other person should be assessed for nutritional assessment. The various tools have been used for nutritional assessment, and among these tools, the Royal Free Hospital Nutritional Prioritizing Tool appears to be the most promising. Some of the other tools have fallacies because of presence of edema and ascites. I'm just sort of showing you the photo that in this Royal Free tool, you look at the patient, see if the patient has fluid overload, and then you score the patient depending on whether the weight loss is planned, unplanned, look at the dietary intake, and then you put the patient to low, moderate, and high risks. Assessment of sarcopenia is done by CT or MRI scans, which are usually done in these patients to look for before transplantation or to look for HCC or any other indication. And you look at the L3 level SMI. The other methods can be DEXA and bioimpedance analysis, which can also be used. However, these may be affected by hydration status, edema. And besides this, a simple thing to do is a hand grip strength, which can be used for muscle strength in cirrhotic patients. So when we assess sarcopenia, we look at the muscle mass, which, as I mentioned, can be either CT-SMI, the bioimpedance, bioelectrical impedance analysis, or the DEXA. The muscle strength can be checked by hand grip strength, and the physical ability. So it's a combination of all the three things, which can be done simply by using a gait speed for 4 meters usual walking speed, and see how much time there is taken off. So some of these cutoffs which have been defined are from available Asian data and some data from India. Now, frailty is a concept which goes beyond just muscle mass. Frailty is defined as a decreased physiological reserve and increased vulnerability to health stressors that predisposes one to adverse health outcomes. It extends beyond sarcopenia and includes muscle function and the patient's experience of the frailty state, like if he's feeling exhausted or feeling sedentary state. There's a lot of overlap between other concepts of muscle health, which includes sarcopenia, disability, decreased energy expenditure, and malnutrition. It's a good predictor of outcome. And we must not just check patients once. We must have a longitudinal follow-up while the patients are on the waiting list for transplantation. There are many ways of checking frailty, and one of them is the liver frailty index, which has components including the hand grip strength, a chair stand, and a balance test. So you look at the dominant hand grip strength using a hand dynamometer. Look at the time to do 5 chair stands with the hands folded across the chest, and you see how much time it takes. Balance test is done by the number of seconds that a patient can balance in 3 positions for a maximum of 10 seconds each. Look at these in the side-by-side, semi-tandem, and tandem. So, and doing all this, there's a formula, and you have an online calculator and description of how to do the test, and a score of more than 4.5 indicates that the patient is frail. Treating malnutrition, as I said, would be adequate calorie intake of going up to 1.5 in people who are malnourished, small frequent meals with complex carbohydrates, a bedtime snack, and a protein-rich breakfast. We assess for micronutrient and nutritional vitamin deficiencies, replace vitamin D deficiency, which is often commonly present. People who have cholestasis, there needs to be a focus on fat-soluble vitamins. Alcoholic liver disease, you replace thiamine and other water-soluble vitamins. Many other things have been tried for sarcopenia, including ammonia-lowering therapy, L-carnitine, testosterone, arginine-enriched, glutamine-enriched, or omega-3 fatty acid-enriched supplements, which have been tried, but the data is not robust enough yet to recommend them. So the exercise recommendations were also formulated in the guidelines. And some of the other highlights of the nutrition guidelines which were there in this document were that nutritional supplements have been discussed, going on explaining about polymeric, monomeric, oligomeric, and hepatic formulas. Nutrition in specific situations have been discussed, including the people with hepatic encephalopathy, critically ill patients, alcoholic liver disease, GI bleed, obesity. There's a large section on nutrition and pediatric liver disease, and probably this is the only document which will also cover extensively the diet and metabolic liver disease, people with galactosemia, Wilson's, fatty oxidation defects, and glycogen storage disorders, etc. So this is a very comprehensive document which goes beyond just the common liver disease. It covers all the metabolic liver disease as well. The document is also associated with appendices, and I'm just giving you some snapshots of the nutritional contents of the common Indian foods, and see what would be the portion size, what would be the energy, proteins, carbohydrates, as to what people would have. It goes further to define or shows a sample, 2000 kilocalories, 70 gram protein, 75 gram protein, fat 30%, 2 grams sodium diet. There is also sections on the sodium contents of various meals, and in this particular diet, the various food groups and servings are there. Like group 1 is milk, and what are the items which will be there, and what should be the amount which goes amount in it. And there is another table which is showing us how to incorporate these protein-rich foods. Dr. Ashish has done a lot of work in this and created a nice table which shows that each of these sections which I showed as per number, and what should be there for breakfast, what should be there for lunch and dinner, and a document showing us what a dietary plan for these patients should be. Thank you. I think I will ask Dr. Dhiman to add a few words, because since he was very closely involved and very keenly involved in the conceptualization of this task force and taking it forward. Dr. Dhiman, please. I think we've lost Dr. Dhiman. Dr. Dhiman, sir, you're muted.
Unmute. Okay. Are you able to hear me now?
Yes, yes, yes. We can't see you, but we can hear you, sir.
Yeah, I was saying thank you so much for presenting in a very short way also. I think
it's a 50-page document. It's impossible to cover it in 15 minutes. So I'm just showing snapshots of what it's about.
Absolutely. I think you did a marvelous job. What I can say, it is basically what I want to say, and you have also commented upon in the beginning of your talk also, that we cannot rely on the Western guidelines also, because our situations are different, our patients are different, and the malnutrition status in our patients and even in the general populations are different actually. Therefore, we need to have a separate guidelines. And considering all those things, we have invited most of the people who are interested in the nutrition also from India. And we have taken at least two persons. One is the Professor Punita Tandon and another is the Professor Murli. So there could be a balance between what are we making the Indian guidelines and the Western guidelines. So I think it is although it is a bulky, and most of the bulks I would say in the annexures as well as in the references, but once you read it, you will find it very uh, easy to read also, and the tables they are supplementing it, I think they are quite informative also. So is the flow diagrams also. So I won't waste much time because we are already running late also, but I would like to say that all the gastroenterologists and the hepatologists or even the general physician must have some idea of this guideline also. I think with these few words, I close here.
Um, uh, I think it's a wonderful exposition by both the people. I think it is a very apt that we should have our own guidelines. May I request Dr. Rakesh Agarwal, are you there, please? Because
Yes,
Anil
sir.
Arora, Dr.
Yes,
Rakesh
sir.
is there. Now, please go ahead, and then you can go ahead for the next session, that an acute liver failure.
So the next presentation will be by Professor Acharya and Dr. A.C. Anand, and that's going to be on acute liver failure. Dr. Acharya, please.
Thank you. Just let me present my slides.
Can I request them to allow me to share my slides?
No, I'm sharing, Anand. You just present after that. I will stop sharing. I'll just, okay.
I think it's already done, sir.
Yeah. Okay.
So, is it all right?
It's all right. Thank you.
Right, we can see the slides. Thank you.
Okay, ladies and gentlemen, this is probably the last but one session of the whole meeting. Welcome to that. And we know on acute liver failure, there are many guidelines. We know about the ESL clinical practical practice guideline, American AGA guideline, as well as the ASLD guidelines. And also from Indian Academy of Pediatrics, there is a guideline on management of acute liver failure. Actually, in Indian National Association of Study of Liver consensus statement of acute liver failure was published in JCEH in two parts. Part one was epidemiology, pathogenesis, presentation, and prognosis. And there are 72 statements. And the second part was basically management of acute liver failure, and there were 101 statements. Do you understand? It's very difficult to cover all the statements in 15 minutes. However, General Anand will take over from me and will present briefly the main and important suggestions. Why we thought we need a guidelines? We all know we had different epidemiology as well as clinical presentation. Particularly, the definition in our setup is different. Our etiology is different. Our drugs are ATT, not paracetamol or NSAIDs. And our pregnant females are more prone to develop acute liver failure, which are distinct in comparison to the West. And we have a lot of ALF mimics like malaria, dengue, scrub typhus, leptospirosis, particularly prevalent in this condition, and their differences from ALF is very important. And we don't have any guidelines for transfer arrangement to tertiary care center, particularly those who need transplant, as well as counseling of patients. And you must have been all are aware that we probably cannot use the King's College or the other scores has been described from the West, where etiology and whole definition and clinical course is distinct. And that's where we have different prognostic methods. And therefore, we thought there should be a consensus guidelines. And these were the members who attended at KIMS, Kalinga Institute of Medical Sciences, where General Anand is the chief. And he was the convener, and I was the chairman. And and this is a huge document, as Pankaj Puri told. And it is all Army's base. It is Brigadier Pankaj Puri followed by General Anand. I will request General Anand to take over and present us these salient features of this consensus guideline. Thank you very much.
So I'll request you to allow me to share my presentation. Otherwise, I won't be able to change the slides.
Should I stop sharing?
Yes, sir.
Okay, I stop sharing.
Thank you, sir, for giving me this opportunity. As Professor Acharya has already told you that the guidelines contain about 175 statements, and we have only about 12-13 minutes left to cover them. So we will just be covering the 4 points that were highlighted by Professor Acharya, and I'll stick to them and I'll not cover rest of it. First is, there was a lot of discussion on the definition of acute liver failure. And this task force defined acute liver failure as an acute clinical syndrome with previously normal liver and presents with acute hepatitic illness presenting either as jaundice or even without jaundice, followed by prolonged INR and encephalopathy within 4 weeks. So I told you there were a lot of discussions, and we have added some caveats for some diseases. For example, previously normal liver, we said that there were exceptions accepted, like autoimmune hepatitis, Wilson's disease, and hepatitis B virus infection. And the reason for that we have given is that overall, when the acute liver failure occurs in these situations, the disease profile and the disease presentation and the disease behavior is just like acute liver failure, and therefore we continue to use it. And in acute hepatitic illness is word I have used here, and I have not used jaundice because there can be an anecteric hepatitis also, which can be followed by acute liver failure. There have been a lot of controversy about the jaundice encephalopathy interval in the literature, and we have chosen 4 weeks as the interval. And this was because most of the patients who come with viral hepatitis to us, they come within actually a few weeks only. They come within 2 weeks actually. And therefore, whatever the classification, acute and hyperacute is being used abroad is not relevant to our cases because all of them will be hyperacute or within 2 weeks or so only. A small proportion of cases will have DILI, where the patients may have ALF with prolonged jaundice encephalopathy interval, and these patients obviously carry poor prognosis. This definition was also able to differentiate between other forms of liver failure, that is severe acute liver injury, where encephalopathy is not there, subacute liver failure, where encephalopathy is not a main feature, but ascites is, and chronic liver failure and acute and chronic liver failure, where features of chronic liver disease are also present. Next, coming to epidemiology, the major difference from the West is the etiology of acute liver failure in India. In South Asia, hepatitis E virus is the commonest culprit. In children, hepatitis A virus may be common, and hepatitis B virus probably is the next common. And then there are other causes, and DILI, which we talk about, we don't talk about paracetamol-induced liver failure, which is extremely rare in India. We talk about anti-tuberculous drug-induced liver failure. Then all etiological workup may be negative in about 1/3 of the cases. And we debated on these issues. And we find that many of these patients may have an infection to other rare viruses, which are not routinely tested. For example, dengue virus, HSV, EBV, or varicella zoster virus. Then there is also use of indigenous medicines, which is common in India. Whether that is a cofactor or not is not clear to us. Different epidemiology is illustrated in this diagram. I've taken three reports from India, which indicate that hepatitis E virus is the commonest cause of acute liver failure in India. And I've taken 3 Western reports to indicate that paracetamol-induced acute liver failure is the commonest in the Western countries. This fact has now been accepted even by the Western reports, and they also feel that yes, the acute liver failure that we see is different from what is seen in the West. I will also show you 2 landmark papers about hepatitis E virus and pregnancy. This is Dr. Khuru's paper, who studied the epidemic of hepatitis E virus in Kashmir, and he found that acute viral hepatitis were significantly more common in patients who were pregnant as compared to those ladies who were not pregnant and as compared to men as well. So the prevalence among the pregnant ladies was about 9 times more common as compared to non-pregnant ladies. And not only that, the second part of the graph shows that those people who developed acute liver failure among the people who had acute viral hepatitis was also about 9-10 times more common as compared to the non-pregnant females and in men. So not only the disease is more common in patients with who are pregnant, the disease is also much more severe in people who are pregnant. This is another landmark paper from All India Institute by Dr. Acharya, who has presented his 20 years data of acute liver failure and acute viral hepatitis seen by them. And when they compared the mortality figures in patients with acute liver failure who were pregnant and non-pregnant and men, they found hardly any significant difference. That means that disease does occur more frequently in pregnant females. Acute liver failure is also more common in pregnant females, but once the acute liver failure occurs, the mortality and behavior of acute liver failure is similar to that which is seen in non-pregnant female and the men who come with acute liver failure. Similarly, as Dr. Acharya said, the differential diagnosis in India is also different as compared to the West. For example, we may have to consider yellow phosphorus poisoning in the differential diagnosis, while this has not been reported much from the Western figure. Dengue fever is also a cause of acute liver failure in India, and often it can also be a mimic of liver failure, but it can actually present with liver failure as well. The other mimics of acute liver failure, which are very common in India, are falciparum malaria, where the cerebral malaria and malarial hepatopathy may coexist, leptospirosis, scrub typhus, and some cases of HLH can also present with acute liver failure. The management principles remain more or less the same. However, what we said was that patients with severe acute liver injury and ALF should be hospitalized, and acute liver failure should be monitored in intensive care units. Measures to contact and transfer to a specialized center or a transplant center should also be initiated in these cases. The relatives should be counseled about the possible outcomes and various options of treatment which are available, and shifting should be done with the consent of accepting unit. And as Professor Acharya has said, we have very poor facilities to transfer such patients, and therefore we recommended that critical care experts, wherever available, should be involved in directing transfer of these patients. The management of complication is more or less same as is described in the West, and there is no new method of treatment that we have advised. One complication, that is AKI, is reported in about 3 to 30% cases, on average 13% cases with acute liver failure in India, as compared to nearly half the patients in the West. And this again is related to the different etiology that we see. In acute viral hepatitis, kidney injury is not as common as in paracetamol-induced acute liver failure. We have also recommended treatment to be given to almost all patients of acute liver failure. One is the N-acetylcysteine, which is a specific antidote for acetaminophen toxicity. However, it can also be used for all types of acute liver failure, and we recommended that it should be used in all cases for with acute liver failure. And similarly, plasma exchange has also been found to be extremely useful in recent reports, and we have recommended plasma exchange to be used in all cases as early as possible. Last is the point about when to transplant, and this point has been discussed at great length in our paper. There are several prognostic scores which are being used in India: King's College criteria, Clichy criteria, somewhere in France, MELD score, MELD sodium, clinical prognostic indicators, and Alfred scores. And I found that most of the transplant centers are fond of using King's College criteria. And the King's College criteria is basically being used because many of our transplant surgeons have trained in UK. But unfortunately, even in UK, they have found whenever these criteria were validated in a different cohort, the negative predictive value was found to be very poor. And whenever a pooled meta-analysis is done in patients elsewhere, it is found that KCC or King's College criteria have very poor sensitivity. It was lower than what was originally suggested in the derivation cohort. And sometime later, people have added post-resuscitation lactate, which was added to King's College criteria, but it is mainly relevant to paracetamol-induced ALF and is not relevant to India. Whenever Indian studies have been carried out, for example, this study from PGI Chandigarh described early clinical prognostic indicators, and these 6 criteria were described. And when they tried to compare it with the other forms of prognostic scales, and they found it was much superior to King's College criteria, which fared poorly in their cohort of patients. Then came the landmark paper from All India Institute of Medical Sciences by Dr. Acharya, who worked on the dynamic model for predicting prognosis in acute liver failure. He had 244 patients in the derivation cohort and 136 patients in the validation cohort. And in both the cohorts, these criteria worked exactly the same. It was measured every day, especially on day 1 and 3, and day 3 findings are considered very significant. These are the 4 parameters which are used: hepatic encephalopathy, INR, arterial ammonia, and serum bilirubin, which are assigned some score. And whenever we find that Alfred score is more than 4, the mortality is extremely high, and these are the group of patients who possibly require liver transplantation. Whenever this was compared with the MELD and the King's College criteria, they found that on day 1 score, again, King's College criteria did not fare very well. But when we looked at the dynamic scores, we found that Alfred score was much superior as compared to the dynamic score of King's College criteria. And therefore, we decided to recommend Alfred score as the method of selecting patients for liver transplantations. So we recommended that dynamic models are much better predictor of mortality than the one-time assessment on admission. And King's College criteria are not very sensitive or specific for ALF in India. And transplantation should be considered as an option for those patients who fulfill MELD, KCH, or any criteria on admission, but actual transplantation should not be done on these criteria. Dynamic assessment of severity should be done by available scores, namely MELD or Alfred score, and transplantation should be considered in those patients who will fulfill the dynamic criteria or dynamic scores. And of course, we should also recognize patients where the transplantation is going to be futile, and in these cases, the transplantation should not be done. To summarize, ladies and gentlemen, what we have said is that acute liver failure is associated with high mortality if not treated properly. The speed of management is as important as what the management actually is done. And comprehensive care keeping all possible complications in mind should be done. Liver transplantation can improve survival, and one should work towards that. Short of transplantation, plasma exchange and N-acetylcysteine has shown promising results. And on admission, the patient's family should be counseled for liver transplantation, and donor's evaluation should start immediately. And the patient's clinical course over next 24 to 48 hours can allow the transplant team to decide if they should go ahead with the transplantation or they should not. If the clinical course allows, the decision to transplant should be taken using Alfred dynamic criteria at day 3. Thank you very much.
Thank you, Dr. Anil. I think you've done a wonderful job for summarizing so many statements into the most useful and also practical, particularly to our country in our scenario. Dr. Acharya, you have any comments before I request Dr. Anil or Dr. Koshi?
I think we are over time and the whole thing has been published. I have no major comment, but specifically General Anand has pointed out the specific areas where we have to focus our effort. Thank you.
Thank you very much. Thank you, both of you. I think may I request Dr. Koshi, please take over.
The next session we have is on fatty liver NASH, and Professor Ajay Duseja from PGI will take it forward. Please, could you start?
Thank you, sir. I think I'll first invite the chairperson of the NAFLD Inasl NAFLD Task Force, Professor SP Singh, to take a minute, and then I'll share my screen and show the consensus statements. Yeah.
Good evening, friends. We are happy to present our consensus statement, which will be published as guidelines very soon. It took us almost 4 or 5 months to have regular meetings to have these guidelines. NAFLD is the commonest liver malady which affects people whether in India or abroad, and it's so important that we are proud to say that India has taken the lead in a call to action against disease. No other country has done so, and on 22nd February this year, the government of India decided to declare the need for action vis-a-vis NAFLD and launch the operational guidelines for integration of NAFLD with their ongoing program, that is NPCDCS, that is the National Program for Prevention and Control of Cancer, Diabetes, Cardiovascular Diseases and Stroke. However, I think they have not mentioned NAFLD in this. They need to change it and add, put one N more in this. But it's a great thing because even the European countries, the American countries have not yet, and they have, though they feel the need to have this, they haven't taken the step yet. And we have taken the lead, at least in this respect. It's a great thing. We have had, I think, multiple meetings all over the country. As far as Inasl is concerned, although this task force was formed in 2007, but it took us, 2015, we published the first position paper. And then there was an imminent need to update the recommendations we had made in this position paper. And that is why we decided to have these guidelines published as early as possible. For this, the process is almost complete. It started in, I believe, in October, November, and it took us all these months to have consensus meetings every week and go through different statements and finalize them. And to present our guidelines, we have Professor Ajay Duseja from PGI Chandigarh, who is the convener of the task force, to make the presentations. Professor Duseja, please.
Thank you, sir. Let me just share my slides. So are these slides visible?
Yes. Yes.
Okay. So as I think has been pointed out, a lot of progress has been made in NAFLD, especially in the various kinds of, diagnostic modalities what we have. And the treatment also is kind of evolving, especially the pharmacological treatment is evolving. And as Professor Singh said, that as Inasl task force, we had come out with this position paper in 2015. So there was a dire need to, update these guidelines. So that is how, the task force decided to have, a new document. And as has been done for the nutrition and the ALF, these have been done predominantly for Indian context. We have guidelines for ASLD, EASL, but then, some of these diagnostic modalities may or may not be available here. Our patients would be different, I think, and the cost and so many other things come in. So that's why we thought that we must have guidelines for Indian context. As said, so what we did, the procedure, I think this was the only guideline which we're presenting today has been done online. I mean, other two were, done as physical meetings, but this was done during the COVID era. And as again, we did multiple Zoom meetings. We started in December 2020 and up to April 2021, we had multiple meetings. Initially, a core committee was formed from the task force, and we decided that rather than getting into the everything, we will focus only on the nomenclature, diagnosis, and treatment of NAFLD. Only 3 things. Then a working party was formed from the NAFLD task force, total of 31 members. And then they were divided into different groups. Each group was headed by a captain, and each group had 4 to 5 members. Each group was then assigned some questions, and they were asked to give answers, and we followed the grade system to answer these questions. And what I'm showing you today are only the consensus statements. And as pointed out earlier, we are still in the process of drafting the manuscript, and these guidelines are yet to be published. But this is the first time that we are sharing it with the journal body of Inasl, the 2020-21 guidelines. So as I said, We started with the nomenclature, and as I said, Dr. S.P. Singh was the captain of this group, and he was accompanied by the 3 other eminent hepatologists here. So in the consensus statement, I think the working party, what we thought was that there's a controversy going on, or a debate going on about the NAFLD versus NAFLD. So a lot of discussion happened and the data was looked into. So finally, Inasl came out with that recommendation that the Inasl suggests that there's no compelling need. So in the absence of a compelling need, NAFLD may be continued as a preferred terminology instead of NAFLD. This is the first, we addressed about the NAFLD versus MEFLD, and we said we need to continue with NAFLD rather than naming it as MEFLD. The other issue, is always about the lean NAFLD. Around 15 to 20% of our patients in practice would be so-called lean, and that is defined by the normal BMI. But Inasl suggests that in addition to normal BMI, absence of central obesity, which would be assessed by waist circumference, may also be taken into account while defining lean NAFLD. And as I said, all these were, given the evidence as by the grade system, and they were also given in the recommendation, whether strong or weak, as for the grade system. The second, area which we looked was for the diagnosis, and we divided that into the non-invasive assessment and the invasive or the liver biopsy. And the non-invasive assessment was headed by Dr. Akash Shukla, and he also had, 3 other members with him. So the recommendations which we came up for the non-invasive assessment were that the Inasl recommends using ultrasound or controlled attenuation parameter or transient elastography as the non-invasive test for the detection and grading of hepatic steatosis.
Welcome to
Also, can I request the others to please mute their mics, please? Inasl recommends that the serum transaminases should not be used for differentiating NAFL and NASH, which is, done many times in clinical practice. Anybody who has raised ALT, people would tend to label them as, NASH, which is probably, there's a poor correlation between the liver histology and the transaminases. So we again debated on this and came out with this. Inasl also recommend using APRI and FIF4 as the initial screening tools for the assessment of hepatic fibrosis at the primary and secondary healthcare levels. For APRI, you just need AST level and the platelets, and for FIF4, I think you just add age and one more parameter, so 4 parameters. So we thought that I think these can be done at primary and secondary healthcare levels. And Inasl suggests that patients with inconclusive results of APRI or FIF4 may be then referred to tertiary care levels, or those who have high, these scores can also be, referred to the tertiary care levels. Then, as I said, at the tertiary care level, I think the recommendations what we gave were that Inasl recommends using elastography, and predominantly we discussed about the transient elastography, but that's the most common, and we have the highest data available with the transient elastography, which is available at tertiary care centers to corroborate the results of APRI and FIF4. If you're getting inconclusive results on APRI or FIF4, if you're getting high results on APRI and FIF4, they need to be corroborated with, elastography at tertiary care level. And for, the cryptogenic cirrhosis or the cryptogenic HCC also is a big thing, and we cannot agree with, the kind of recommendations which ASLD has given, that you need to have a tissue diagnosis for calling them as NASH cirrhosis or NASH HCC. So the Inasl suggested that the diagnosis of NASH cirrhosis and the NASH HCC can be made non-invasively by excluding other causes of cirrhosis and HCC, and in the presence or history of overweight and obesity or central obesity and one additional metabolic risk factor. So if you have history of obesity or presence of obesity or overweight and one additional metabolic risk factor, and you have excluded all other causes, I think you can probably make, but as I said, the recommendation obviously for this was weak, but this is how we thought that in Indian context, I think this would be very, very important. Coming to the liver biopsy, which was headed by Dr. Shalimar, and we had a pathologist, Professor Acharya, Dr. Manas from, as the team members, and in the liver biopsy, we all agreed that the liver biopsy still remains the gold standard for the diagnosis of NASH. We know NASH is a histological diagnosis. We cannot probably make the diagnosis without biopsy. But then having said that, we also said that that the liver biopsy is not routinely required for the management of NAFLD in day-to-day clinical practice. We know the issues which are involved with liver biopsy, including the patients. Most of the patients may not agree for liver biopsy. The acceptance is poor. Then the complications of liver biopsy. So we said that on day-to-day clinical practice, I think it may not be required. And Inasl recommends using non-invasive tests for the assessment of hepatic steatosis and fibrosis in clinical practice. But having said that, liver biopsy should be considered in patients where the non-invasive assessment of hepatic fibrosis is discordant, or where the other competing etiologies of hepatic steatosis or liver disease cannot be ruled out. So whenever there is a confusion, yes, you can do a liver biopsy, but in routine clinical practice and routine management of patients with NAFLD, I think the liver biopsy probably would not be required and the non-invasive assessment would be good enough. Then we had a group which looked at the NAFLD is a multisystemic disease, can be associated with various hepatic and extrahepatic manifestations. So we had a group which was headed by Dr. Kaushal Madan and Dr. Anil Arora, Dr. Krishna Das, Dr. Saswat, and we also had one a nephrologist and one cardiologist in this group, and they also contributed to this. And what we came out with the consensus statements were that the presence of steatosis in patients with chronic hepatitis B and C augments the risk of hepatic fibrosis, cirrhosis, and HCC. And I think there's a lot of data on this internationally and even from our country. So we said, yes, if you have fat associated with this, and even in alcohol-associated liver disease, if there are metabolic risk factors which are associated, they tend to increase the severity of alcoholic liver disease or alcohol-associated liver disease. Also, the data was discussed about the risk of extrahepatic malignancies. HCC, I already said. So in the extrahepatic malignancies, I think the NAFLD could be associated with increased risk of extrahepatic malignancies. And mind it, these are only the evidences we are given here, and there were no recommendations which were made because they were only statements which were given here. And then finally about in patients about their renal evaluation and the cardiac evaluation, Inasl suggests that the patients with NASH, with or without advanced fibrosis, and those with concomitant type 2 diabetes may be evaluated for impairment in renal functions. Now, how this evaluation has to be done, what tests ought to be done, we will all give them in the text. And we have already done the consensus for that, whether you need to do a urine examination and what you need to look at the GFR, everything I think we would be giving in the test. But these I am presenting are only the consensus statements. Similarly, Inasl recommends that in patients with NASH, with or without advanced fibrosis, and those with, again, concomitant type 2 diabetes, should be evaluated for the presence of cardiovascular disease. There's always, a debate that who are the patients who should be evaluated for cardiovascular disease. Pre-transplant, it is pretty clear, but otherwise transplant, the data was discussed. We made a strong recommendation, even though the evidence was not very, very high, but still, I think we thought that those with high fibrosis and those with diabetes probably should be evaluated for this. Then coming to the treatment part, and we divided the treatment into the lifestyle interventions and the control of risk factors, and we divided them into the pharmacotherapy, and last was the liver transplant. So this lifestyle interventions was headed by Professor Gaurdas Chaudhary, and then Dr. Ashish Kumar, Dr. Pritam Nath, and Dr. A.C. Anand. They were all part of this, and we came out that Inasl recommends the weight loss of 7 to 10% from the baseline, which should be induced by a combination of diet and exercise as the primary treatment for overweight and obese patients with NAFLD, for improvement in all three components of NAFLD, which is steatosis, inflammation, and fibrosis. Also about the diet calorie restriction, the Inasl recommends 30% reduction in calories from the baseline, or 500 to 1000 kilocalorie per day reduction in calories to achieve this target weight loss, which, as I said in the first statement. And regarding the exercise, it was agreed upon that irrespective of the body weight, even if it is a lean NAFLD, the exercise of moderate intensity, aerobic or resistance every day or at least 5 days a week, 45 minutes to 60 minutes, should be recommended in all patients with NAFLD, irrespective of body weight. Then about the management of diabetes and dyslipidemia and hypertension, it was agreed upon that they have to be managed on the standard guidelines or standard recommendations as applicable to non-NAFLD patients. And the only statement what we thought was, because there's always sometimes a problem especially among physicians about using the statins, especially if they have raised transaminases. So we came out with the statement that the statins, if indicated, can be used safely in patients with NAFLD, even in the presence of transaminases. The only thing you need to be cautious is in decompensated cirrhosis. As I said, then coming to the pharmacological and the bariatric treatment, this was looked after by me, and I had Dr. Arkade, Dr. Narinder Chaudhary, Dr. Epan, and Dr. Nijaman with me, and we came out with the statement that the pharmacotherapy should be considered in patients with liver biopsy proven NASH with or without hepatic fibrosis. So if you have a liver biopsy which shows biopsy proven NASH with or without hepatic fibrosis, no doubt they would require this thing. But then I will also show you where the biopsy is not available. I think we also came out with that recommendations. Amongst the drugs, we recommended vitamin E for predominantly non-diabetic patients, adult and pediatric, and for pioglitazone, we recommended both in diabetic and non-diabetic. And also we came out with a statement about the Indian molecule, which is saroglitazar, that it can also be recommended both in diabetic and non-diabetic in patients with NASH with or without hepatic fibrosis of F1 to F3 fibrosis. But then, as I said, we also came out with this, that where the liver biopsy is not available, and as I said, it is not recommended for routine clinical practice. So the NASH specific pharmacotherapy, which we have already discussed, can be used in non-cirrhotic patients found to have significant fibrosis on non-invasive assessment. Suppose you're getting a patient who has an LSM of 9. So this is what we defined 8 as a cutoff of significant fibrosis. And even if the patient is not ready for biopsy, you can take a decision of treating him with NASH specific pharmacotherapy, which I already said. I think the new kid on the block, or this was again discussed among the working party, that we must put statement about the obeticholic acid, because this is available for usage in PBC, and people tend to start using it for even for NASH because of the recent data which has come up from the Regenerate trial, even though the FDA has not recommended. So we came out with the evidence that pending further evidence, Inasl suggests not using obeticholic acid as pharmacotherapy for NASH, and pending evidence Inasl also suggests that not using NASH specific pharmacotherapy in NASH cirrhosis, because again there's some data which has come up about the usage of metformin and vitamin E in patients with NASH cirrhosis, but we thought that they were retrospective studies and we need little more data before we kind of recommend these statements. About the bariatric surgery and the endoscopic bariatric treatment, we came out with the statement that in the absence of randomized controlled trials, bariatric surgery cannot be recommended as a primary treatment in patients with NAFLD and NASH. So otherwise, if it is indicated in obese patients, we said it can be done in the presence of non-cirrhotic NAFLD and NASH, but not as a primary treatment, and I think everybody agreed on that. But then we also came out with a caution that you should be very cautious about the bariatric surgery in patients with compensated cirrhosis, and because of the high mortality which is associated, it should be avoided in decompensated cirrhosis, unless it is being done as a part and parcel of, sometimes you tend to do a liver transplant and a bariatric surgery together. Otherwise, I think we said this would be very, very risky. Also, for the bariatric endoscopy therapy, we came out with the statement that in the absence of randomized clinical trials, endoscopic bariatric therapy cannot be recommended as a primary treatment in patients with NAFLD or NASH. I think probably we need more evidence on that. So finally, I think this will be my last 2-3 slides about the liver transplantation, and this team was headed by Dr. Sanjeev Sehgal, and he was associated with the other members were Dr. Manav, Dr. Neeraj Saraf, and Dr. Manoj Kumar. And the statements which we came out were that the Inasl recommends that the screening and assessment for comorbidities, the presence of comorbidities in patients with NASH cirrhosis would be a big challenge. Many of them would be obese, many of them would have diabetes, many of them would have hypertension. So that screening and assessment of comorbidities, I think, is a major issue. But then the transplant physicians and the overall working parties thought that the assessment of these comorbidities in NASH transplant recipient should be done in the same way as for other etiologies. There's nothing specific which needs to be done. So as other patients are also being evaluated for these comorbidities, they need to be done. And also that the algorithm for cardiovascular risk assessment can be determined by the local expertise, at how far you want to assess the cardiovascular risk in a patient with NASH cirrhosis who's being worked up for liver transplant. That can be done by the local expertise, whether you want to just do the non-invasive assessment or whether you want to do the CART or angiography. I think we came out with that. And similarly, I think the Inasl recommends appropriate screening and management of the renal dysfunction before and after renal transplant. And this was probably my last slide. The post-liver transplant survival again was discussed, and this is just a statement that the survival in these patients is similar to other etiologies. There is no recommendation here. But then about the immunosuppression, again, we, I think, discussed in detail, and it was agreed upon that the steroid should be tapered as early as possible, maybe within the first 3 to 6 months. And out of all the immunosuppressant drugs, I think mycophenolate could be the safest, in these patients, those who are undergoing liver transplantation. And post-transplant occurrence of fatty liver disease, either a recurrent NASH or as a de novo NAFLD or NASH, is again a very common problem. But then in the absence of, again, good data, the Inasl came out that these patients should be managed with only lifestyle interventions and without any specific drugs, because really we don't have any data about the usage of these drugs. So thank you very much all, and I would like to acknowledge the contribution of all the Inasl NAFLD working party members for making these consensus statements, and for the technical support. I would also like to thank Dr. Reddy's Labs for the kind of various Zoom meetings, which, as I said, multiple meetings we did over a period of 6 months. So thank you all, and I'll stop sharing my screen.
Thank you, Ajay. This is an excellent talk. I have some reservation. You mentioned treating F1 to F3, which means including F1 with possibly saroglitazar or pioglitazone. I have my reservation on treating F1 with such drugs. You have some comments on it?
Yes, sir. So if you read, I think before that we have written NASH. So if they have NASH or with or without fibrosis. So if you have NASH, that makes your entry point for treatment, even if you don't have fibrosis, even if the F is 0. So if you have NASH, I think that would be obviously histological proven. But then for the non-invasive assessment, we said you need to have significant fibrosis. Then you can take a decision if you don't have a biopsy. So if you have histological NASH on biopsy, even without fibrosis, there is an entry point for treatment. This is what we discussed here.
Yeah, the reason why I have reservation is we know that it takes a very long time from F0 to F1. Could be as long as 10 years. And again, from F1 to F2, it takes considerable. After F2, it speeds up. And I don't think we have data on clinical outcomes of patients treated with F1.
Right. I think we can always have a rethinking. As I said, they are still, this is still the work in progress. We are actually asking for comments from, senior people like you and others. So we are still, as I said, we're still drafting the manuscript. We are discussing with the working party. It was all done as an online thing, but this was what was discussed. So that is what I am presenting. So if you have histological NASH, even with fibrosis, we thought we should be treating. Yes, Professor Agarwal, I think.
I have the same concern for F1. And the second thing is, do we have data on 60 minutes of exercise, daily? That's a whole lot of exercise. For most people, nearly impossible. Are there data on 60 minutes per day?
If I remember right, sir, I think taking your second question first, I think 45 minutes to 60 minutes, I think is the range we have given. And I think there are studies, especially the Villar Gomez study, which was probably the largest on lifestyle interventions, published in 2017, I think, in gastroenterology, did use these guidelines for lifestyle interventions, and that was the main study which we took as our landmark to take those recommendations. I think it is 45 minutes to 60 minutes. I can recheck.
Thank you. Ajay, how much of the data is India specific?
India specific is predominantly on the non-invasive assessment. If you look at this, we don't have ELF, we don't have MRI, we don't have MRPDFF. This is all India specific. Ultrasound, APRI, CAP, FIF4, they are all, bedside tests. So these are all India specific.
No, but India specific data for that would mean that there are data comparing that to biopsy and showing that non-invasive works. Those data from India are extremely scanty. We really can't call it an India specific data.
Sir, I agree, sir. But if you look at the recommendations and the evidence,
this is true for all our task forces. They are really, let me say, fact that people may not be very happy with. Most of our guidelines are heavily ASLD or Inasl based. Acute liver failure is something slightly different, but almost all are exactly there. If anything, we should really be talking about low-cost solutions and thinking where treatment is needed or not. But generally, what we end up doing is where treatment may be given, changes to must be given. See, for instance, we were talking a little while ago of even ALF. And we talked about some treatments, NAC, in other forms other than paracetamol. Where is the data? Right? Data is extremely limited. We talked about plasma infusion therapy. Where is the data? Are those very reliable data? So Indian data is definitely not there. So this is not only for this. This is actually the way we are.
Agree, sir.
Sorry for this, but that's how we are.
No, I agree, sir. I think the evidence again we had given was not very high. Yeah, sure.
And Ajay, second is, a major chunk of these patients may come to you at a very late stage. You see, you have endocrinologists, you have cardiologists, you have physicians following up these patients for years. They never bother to even have an ultrasound. And the first time they will, have thrombocytopenia, they'll send to a hematologist till they find out that the patient had an underlying cirrhosis with hypersplenism. Why is it that we do not increase this awareness? Because only a small proportion of the patient will come to you. Majority will get stuck up. If you are diabetic, endocrinologist will never leave you alone. If you ever had a chest pain, you're always stuck up with a cardiologist, where where by the time CLD is diagnosed to be related to NFL, it's too late. So do we ever integrate those?
Yeah, we have discussed, I agree with you. I think we have discussed only about the patients with NAFLD as a hepatologist perspective, right? We did, had, in the group, if you were part of the group, I think the cardiologist and the nephrologist with us, right? But then everybody, in the group that time suggested that let's talk from the hepatologist perspective, that whether the patients, those who are coming to you, how far will you go in working them for the renal issues and the cardiac issues? Let's not for the time being discuss about the patient, those who are coming to the cardiologist or the nephrologist. So this is what was, discussed in the working party, but again, open to discussion.
Thank you very much, Ajay and SP Singh. I think we have been asked to close the session. We are run out of time. Thank you very much. Very excellent discussions.
Thank you, sir. Thank you very much. Thank you.
I want to thank all for this wonderful program, and we've had 3 days of very interesting talks and active participation by all the faculty, and even good participation by the delegates, students, PhD students as well, sir. I thank all, and I also want to thank the technical team for their support, and I request all to join for the valedictory function in Hall A. Thank you so much.
Thank you. Thank you.
Thank you.
Sir, what do you do by diagnosing NAFLD in a person who's already diabetic and is being cared for? how does it change things? He's already possibly, diabetes is being controlled, he's being told to take precautions for heart disease. He's being asked to do exercise. What will you do by diagnosing it?
I think all you can do is tell him he has an additional factor to incentivize him to be more rigorous with his treatment.
I don't know. So that, anyway, that's it. See you in hall 1, sir. Thank you.
Thank you.